All right, everybody, welcome back. Hope everybody's doing well today and adjusting to being back in school, back in the term. All right, so first off, before we get started, I know we don't have a lot of people attending live, but the people that are here are people that were here last week. So, does anybody have any questions on anything regarding any big picture questions about the comps or anything related to last week? Now that you've had a week to digest and maybe think about this a little bit. Okay. If there's no questions for now, that's fine. But just, at any point, if questions come up, you could ask in class, you could email me, whatever. Just let me know. All right. Otherwise, if there's no questions, I'll just kind of dive through it and recap. But really the review class can be whatever people make it out to be. But it seems like in recent years, since we've been online, it's more so been people watching the recordings. So it is me more like sort of like a little lecture, if you will, like kind of going through topics and hitting all the key points. But, if people have more questions, want back and forth, whatever, we can turn this into essentially whatever you want it to be. But the majority does seem that they're watching the recording. So obviously I have to go through something. So anyway, just jump in whenever you want.
Yeah, I'm just curious, what handout is this?
This is the handout we left out off with last week. So it's the notice all the handouts you can see they're labeled at the top. So it says bio,
Okay,
autoimmune, genetic. So it's the same handout we were finishing up last week. We just didn't get to the cancer part.
thank you.
Yep. All right, so wrapping up the handout from last week, this is a bio topic. So last week, remember, we had started going over autoimmune disorders. We started going over genetic disorders. We basically completed those and cancer. So this would all be within like the pathophys, and that's in the broader bioscience section. So this will all be bioscience related stuff. So there's definitely a good handful of questions in the test bank regarding tumors and cancers. And so we'll start there. First off, there's just some terminology that tends to come up. It doesn't all directly relate necessarily to tumors or cancers, but it tends to come up related to this topic. So, like hypertrophy, for example, they just expect you to know the definition that hypertrophy is essentially when a tissue enlarges because the individual cells increase in size. The most common example of that is muscle hypertrophy. When you go to the gym and you engage your skeletal muscles, the reason your muscles get bigger is because the individual cells are enlarging. They're making more myosin, they're making more actin, they're storing more oxygen, they're storing more glucose. That's part of conditioning. So in order to have more of those proteins and store more oxygen, et cetera, the cell increases in size, and the collective action of multiple muscle cells increasing in size leads to what we see with the naked eye as, just overall muscle hypertrophy. Now, that's not really related to cancer, but the reason that we go over this term is because there could be questions about this next term, hyperplasia, and people often confuse hypertrophy and hyperplasia. So, hyperplasia is when there's an increase in the number of cells. So, in other words, hyperplasia implies cell division. There's an increase in the number of cells. So whatever the number was before 1,000, maybe now there's 2,000, just to make something up. So hypertrophy, the cells that you have get bigger. Hyperplasia, you make more cells. So it involves mitosis, it involves cell division. And that comes up in this topic because cancer, if nothing else, is cell division gone wild. It's basically unregulated cell division where the cells are copying themselves without good reason and they're sort of taking over the tissue. And so these definitions come up kind of within this general topic. Now, when you get a growth that's growing, outside of the normal boundaries and a different orientation than how the tissue normally grows, that's what they refer to as a neoplasia or neoplasm. And that's another term for a tumor. So sometimes you'll see those used interchangeably, the word tumor or the word neoplasm or neoplasia as a general category, meaning new growth. Mhm. Then also under this umbrella, you may have references that come up to apoptosis or necrosis. Remember, both those terms relate to or refer to cell death. The difference is that apoptosis is programmed cell death. Like it's not pathological, it's part of the plan. So in other words, your skin cells, for example, as skin works its way to the surface and gets further from the blood supply, it's normal that the cells die. Then there's several outer layers of dead tissue that provide a little bit of a barrier between living tissue and the atmosphere. And eventually they get far enough from the surface that they are far enough from the blood supply and closer to the surface that they essentially flake off. We shed them. Well, I mean, technically that's cell death, right? Those were skin cells that were living at one point and now they're not. But that's part of the plan. That's how we turn over skin cells. That's how we get rid of old skin cells and then replace them with newer ones from the inner layers. So apoptosis is a type of programmed cell death. It's the same kind of thing when we break down old red blood cells in the spleen. Nothing pathological there. But this does come up in relation to tumors and cancers because when it comes down to tumors developing, or whether that tumor be benign or malignant, one of the underlying issues might be that apoptosis is not happening the way it should. It may be that there's some cells that are supposed to die off, but they're not. And that can be one of the contributing factors to developing a tumor. So again, the term might come up on the bio portion of the exam. And you just want to compare that to necrosis, where remember that necrosis is also cell death, but that's the unplanned, unprogrammed, unregulated cell death. That's more like an injury. You put your hand on a stove, you kill a bunch of skin cells. That would be necrosis. In other words, it's not programmed. It's not programmed for. It's not part of the plan. And then lastly, as far as a few definitions go that can come up here, you may hear the terms metaplasia or dysplasia. Metaplasia, the prefix meta just refers to change, like metamorphosis, for example, it refers to change. So metaplasia basically just means when there's a change from one mature, differentiated, fully developed cell type into another. And the most common example of that, simple example, is normally our respiratory tract is made up of columnar epithelial cells. But when people smoke, that damages the cilia on those cells, which damages the cell membrane of those cells. So, in other words, the cells get damaged. Chronic, regular recurring smoking damages those cells. And the body, therefore, has to keep replacing them. Well, eventually the body's like, all right, this cell type isn't working. That they keep dying off. There's something about the environment that keeps killing these cells. Let's try a different cell type. Maybe this other cell type will do better. So it changes over time into making multiple layers of thin, flat cells, what we call squamous cells. And that change from columnar cells to squamous cells is commonly seen in smokers. That's a form of metaplasia, basically changing from one mature cell type to another. Maybe this other cell type will do a better job. Now, that is not cancer, but that can be the beginnings of changes that ultimately take somebody in the direction of cancer, because then that eventually the person can develop what they call dysplasia. This is where the cell turnover is so fast that there's not even time to make new, fully mature, fully differentiated cells. So what happens is immature, undifferentiated cells, basically stem cells, cells that really have very little functionality to them. They're not fully developed. They're not fully matured. They don't have all their organelles present. They don't have all the specifics that make the cell a certain type of cell present and developed. So essentially, immature cells start filling in the gaps. There's been so much tissue damage that the body just can't keep up with replacing these cells. It takes time, it takes resources to constantly turn over cells like this. So eventually, they might start to see an accumulation of immature, undifferentiated cells. And the growth pattern might be haphazard, because again, the body's trying to keep up with a tissue that keeps getting damaged, and the growth pattern might become haphazard after a while. It's doing its best to fill in the gaps, but maybe not very effectively. So it leads to this disorganized growth pattern. This is what we call dysplasia, and this disorganized growth pattern of undifferentiated cells, this could be the precursor to a tumor. This could be a precursor to cancer. So that's why, again, these terms could come up related to this larger topic. So nothing too technical. It's mostly just for this part here that was what we just went through. You want to be able to recognize these definitions. Make sure you don't flip hypertrophy, hyperplasia. Make sure you don't flip metaplasia, dysplasia, that you know the gist of what these words mean. Any questions on any of those? Then tumors, remember, when a tumor develops, in other words, the person maybe has some kind of growth, some kind of mass. Tumors, remember, can be biopsied and be determined to be either benign or malignant. And those are also some questions that can come up here is what is it that makes a tumor benign versus makes a tumor malignant? What are those characteristics? And the key thing is what we were mentioning a little bit ago with dysplasia. Benign tumors are composed of mature, well differentiated cells. In other words, the cells resemble their tissue of origin. There might be too many of them. They might be growing in an abnormal orientation, leading to a mass. But basically, when you biopsy them, the cells resemble the cells that belong there. Like, I gave the example here. If it's a bone tumor, it's bone cells that make it up. So mature cells like that tend to be more slow in dividing because, basically the more complex the cells are, the more developed they are, the longer it takes to copy them. So when you have a tumor composed of mature cells, the tumor tends to be slow growing. Because it's slow growing, it stays within certain boundaries. So a lot of tissues are surrounded by connective tissue, and it stays within those boundaries because since it's slow growing, the connective tissue can grow with it. So it tends to be encased within connective tissue. People refer to that as a fibrous capsule in the context of tumors. And these cells tend to have a good adhesiveness to them. They don't break away. They don't metastasize. They don't infiltrate into other tissues. They just kind of keep growing and expanding. So it might press up against something, but it doesn't invade. It doesn't grow into tissue spaces. It doesn't metastasize. It just kind of keeps expanding out. So those are some of the characteristics that make a tumor benign. Now, on the other hand, if the tumor is malignant, the key thing is here, there's more immature, undifferentiated cells filling in the gaps. Again, more like stem cells. These cells don't resemble the tissue of origin. These are just very immature, generic, underdeveloped cells. But the one thing those types of cells do really, really well is divide because they're so simple, they can copy very easily. It's very easy to copy them because they're really simple. I mean, a silly example would be like, if somebody gave you a stick figure, a picture of a stick figure, and said, okay, like copy that on another piece of paper, it'd take you 2 seconds, pretty easy. But if they gave you the Mona Lisa, like, okay, like now based on that picture, draw your own. Well, that's more complicated. It's going to take a lot longer. If you have the skill set and everything, it would take a lot longer to do. So the same kind of thing here, like very simple cells like stem cells, very quick to copy themselves. So that's why these types of tumors divide very rapidly. They grow outside of the normal boundaries because they grow so rapidly. So they're breaking through surrounding connective tissue. And for that reason, they are invasive. They do grow into other tissue spaces. And pieces break off sometimes and travel. They get into the lymph, they get into the blood and travel to other locations and then attach somewhere else. And then they lead to secondary tumors. That's what we call metastasis. So cancerous tumors or malignant tumors, they behave in that way. That's why they're much more dangerous. because once they start growing, they kind of take over the tissue. They grow rapidly, they grow into the tissue spaces and they take over. And now you have all these like abnormal, non functioning cells consuming resources and taking over the space. And then the organ eventually starts to fail because, the healthy cells are being, they're losing resources to these other cells that are consuming oxygen and everything else. And they're like, taking over the space. So there's not as much room for the healthy cells to grow and divide. All right. So make sure you know some of those key characteristics, some differences between benign and malignant tumors. Those things tend to come up quite a bit. Right. And actually, just one quick, actually, no, I'll mention that later. And then also, you want to recognize the naming. So remember, if you see the suffix oma at the end of a tissue name, like so, for example, you might remember that osteo refers to bone. If you see oma at the end, that's telling you there's a tumor. So basically, whenever you see oma at the end of a word, that's telling you that there's a tumor, some kind of growth on the relevant tissue. So osteoma is a tumor of bone, adenoma is a tumor of a gland, lipoma is a tumor of adipose tissue. If it's cancer, though, like if it's known to be cancer, you'll see the terms carcinoma or sarcoma come up. So if it's epithelial tissue, which would be things like skin, glands, um, the inner lining of your GI, if it's epithelial tissue, you'll see the term carcinoma used. So instead of just adenoma, meaning tumor of a gland, it'll be an adenocarcinoma, meaning a cancerous tumor of a gland. So whenever you see carcinoma or sarcoma used, you know that it's cancerous, meaning it has these kinds of characteristics that we just mentioned for malignant tumors. If it's connective tissue, that would include things like bones, cartilage, fat, if it things like that. If it's connective tissue, you'll see sarcoma used. So instead of an osteoma, it would be called an osteosarcoma. If it's cartilage, the tissue, the tissue root is chondro. So it'd be called a chondrosarcoma. So again, you just want to be able to recognize from the names whether certain tumors are cancerous or whether cancerous or malignant, another way of saying it, or whether they're benign. You will get a few questions potentially on that kind of stuff. Any questions there? And then, of course, you want to be able to recognize like the red flags of cancers. So if somebody tells you about certain symptoms that they're having, there's certain things that should raise a red flag that make you say, I should probably send this person to their primary care physician to be looked at, to assess. Look at an MD to assess for this. You don't necessarily have to use the word cancer, but you could say, well, some of these signs are a little bit concerning. It might be something outside of my scope. So I just want you to go to your medical doctor to, just kind of get screened and make sure that everything's clear before we continue. So those are things like unexplained. The word unexplained comes up a lot. Like, right, like obviously people lose weight if they maybe decide to go on a vegan diet or they're exercising more or something like that. But if nothing has changed, like they're still eating the same, they still have the same activity level, but they're noticing that they're getting this unexplained weight loss, that needs to be examined because tumors essentially eat up a lot of nutrients. Those rapidly dividing cancer cells consume a lot of calories. So that could be why somebody is losing weight unexplainedly. Fatigue, same kind of thing. Again, if there's a reason for their fatigue, like, oh, really stressed at work, okay, maybe you're not as concerned. But if it's just like, yeah, lately it's just been getting worse and worse, and I don't know why, gotta have that examined. Anytime there's some kind of unexplained growth, any kind of bump, any kind of lump, always have to have that checked out. Unexplained pain is a key thing. So again, it's one thing if it's an injury, if somebody sprains their ankle and it hurts, but some kind of like particularly internal pain that's deep, boring, hurts in all positions, even when they're just laying down. Like that's the key thing about night, is like even when they're laying down, not doing anything, it still hurts. It's not like a sprained ankle, like, okay, it hurts when you walk on it. But like even when they're laying down doing nothing, they still have this pain. That implies potentially it could be a tumor that's growing and it's pressing on something. It's pressing on something internally. That's why it doesn't matter what position they're in, or even if they're active or laying down, those things always have to be checked out. Bleeding. As tumors grow within tissue spaces, they damage capillaries. Remember, all your tissues have a lot of little microscopic blood vessels in there, arterioles, venules, capillaries. As the tumor grows, it can damage those blood vessels, and then they get bleeding. The bleeding might be internal, or if it opens to an orifice, there might be like blood that's coming out. So they might be getting nosebleeds, vomiting blood, blood in the stool, blood in the urine. Just depends on where the tumor is. But any kind of unexplained bleeding has to be checked out. And then of course there's sort of the catch-all, any kind of like change in organ function, any kind of change in like bodily function should be checked out. So if they just notice like, oh, developing a chronic cough, you know, well, could be could be throat cancer, could be lung cancer. They're noticing they're having difficulty swallowing, could be esophageal cancer, could be stomach cancer. Change in bowel habits, could be colon cancer. Pencil thin stools, that's usually the stools having to get around the tumor, so it comes out very thin. It has to kind of squeeze past the tumor. So any kind of change in bodily functions where it's a chronic change, not like one day they were coughing a little bit, but where there's a chronic change, it's getting progressively worse. Those are the kind of things you always have to have checked out. All right. So just keep some of those things in the back of your mind. Key red flags. These are the kinds of things you want to refer out for. Then cancer labs. So there's a few laboratory findings that if you get told this lab on an exam, it basically tells you that the person has a certain type of cancer. And you don't even really have to think any further. So there's a few things from your pathophys classes that just like if you see this, you don't even have to really give it further thought. You know the answer. So Reed-Sternberg cells, those are something that are found on a biopsy. They indicate Hodgkin's lymphoma. You see something about Reed-Sternberg cells, it really doesn't even matter what the rest of the case says, just Hodgkin's lymphoma. There's a genetic test, what they call Philadelphia chromosome. This puts a person at risk for chronic myelocytic leukemia, CML for short. You see something mentioned about the Philadelphia chromosome, again, don't overthink it, just chronic myelocytic leukemia. None of the questions on the comps are trick answers. So, I mean, if they're telling you something like Reed-Sternberg cells, the answer is not going to somehow be something else. So, I mean, don't go down that road of, well, that's too obvious. No, no, it's that they're testing to make sure you know that. If it's obvious, it means you know it. So that's good. Bench Jones proteins, you find those are things you find in the urine. That indicates multiple myeloma. And the last one's kind of obvious because PSA stands for prostate specific antigen. So elevated PSA levels could be an indicator of prostate cancer. So what they might do on an exam is, they might use the abbreviation PSA, and you have to know that because it's a very common abbreviation. So they might use the abbreviation PSA, and you have to know that's referring to the prostate specific antigen and might indicate prostate cancer. And just a couple things about breast cancer, because there'll be some specific cancers that will come up in other topics that we go over, but breast cancer doesn't really come up so much in the other topics that we go over for the comp review. So I just want to highlight a few things here. They do ask sometimes about the risk factors. So you want to remember like the BRCA gene. If somebody tests positive for BRCA gene, that, I mean, what they'll say biomedically is that the person will at some point develop breast cancer. It's just a matter of when, but not if. The older the age, the more likely, female, more likely. And remember that elevated estrogen levels or high exposure to estrogen levels over the years can increase the odds of breast cancer. It doesn't mean that somebody like, will develop breast cancer, but the more estrogen exposure somebody has had throughout their life at the higher levels, that can increase the risk. So things like early onset of menses, what they call early menarche. The earlier that is, like in other words, somebody who starts menstruating at like 10 years old or something, they have like maybe 3 extra years of higher estrogen exposure. That can increase the risk. Late menopause, same thing. Somebody that doesn't go through menopause until 57, that's more estrogen exposure over a long period of time. No pregnancies increases the risk because during pregnancy, the hormone balances change. There's more progesterone being produced. And progesterone actually has been shown to lower the risk of breast cancer. So, no pregnancies throughout someone's life can increase the risk. Now, somebody could have all those risk factors. I mean, with the exception of BRCA, which is considered to be pretty much a guarantee. But that one aside, somebody could have all those risk factors and not develop breast cancer. So, just keep in mind these are things that increase the risk, they're not guarantees. And for that reason, you should know that for a number of breast cancer types, one of the medications used to treat it would be estrogen receptor antagonists, basically drugs that block estrogen receptors on the breast tissue. So, therefore, the breast tissue doesn't receive that estrogen stimulus. So, it kind of makes sense if estrogen is sort of promoting the cancer growth in some ways, blocking those receptors can be one of the treatments for it.
Didn't they debunked the like tofu has estrogen or like can up your estrogen levels? Like, isn't it? It's pretty hard to do that through nutrition, right?
That's my understanding. I mean, with things like that, like it's like they change all the time. One study completely reversed what we previously thought, and oh, never mind. Now there's this new study that. So, like, I feel like that kind of stuff changes a lot. You never know, but yeah, my understanding is at this point, they even though there are some phytochemicals in tofu or in soy in general that resemble estrogen, it doesn't have like it's not a strong enough effect that in terms of this kind of stuff that it makes much of a difference, is my understanding. At least as of right now, until until they change it. Any other questions on that? And just one other thing on this topic that I want to mention before we change topics is cancer metastasis. There is one particular question in the test bank that it doesn't necessarily come up on every exam because again it's in the test bank, and the software randomly pulls in questions from the bank, so you never know which questions will come up on an individual test. But there's one question in the test bank that comes up, and every single time this question comes up, it gets flagged, meaning a certain percentage of students missed it, and so therefore the deans, the department chairs give it a second look. And I mean, like every term we kind of laugh up, there's that question again every time. And even though knowing that this comes up every time, like when I taught pathophys, I always emphasize this point. In the review class, I emphasize it. It's still every time it comes up, comes up, comes up. So we'll see. I'm going to mention this again. If you get a question that, essentially talks about for an extended period of time, somebody was having a certain set of symptoms, because I can't give you the exact question, but somebody was having a certain set of symptoms for an extended period of time. In other words, implying that maybe something was wrong with this organ or that organ. And they're telling you it's chronic, it's been getting progressively worse over the course of a year or two. That could be possibly implying cancer, like we were just saying, if somebody has any kind of changes to bodily functions. So, for example, a cough that over the course of a year has been getting progressively worse, it's lasted a long time, difficulty swallowing, etc. If it's prostate, urinary problems, things like that. And then they tell you, here we are like a year later, 18 months later. Now they're getting signs somewhere else. Now they've got bone pain, that's unexplained. What do you think that's implying? Perhaps just the people that are here. What do you think that's implying? Like they've had these things going on for a while, organ dysfunction, maybe cancer. And now it's somewhere else. Now they've got bone pain. You know, now they're getting, whatever it might be, like digestive problems or any ideas what that might be hinting at? What's something that cancer can do regarding different locations?
And spread to other areas of the body.
Exactly. It's implying cancer metastasis. So if you get a question where it's something like that, they've had these symptoms for a while in this area. There seems to be some kind of dysfunction going on affecting this bodily system. It's been going on for a long time. Oh, but now symptoms, they seem to have something else going on in a different area. That's more recent. That's implying cancer metastasis. That's not to say it couldn't be something else, but on this particular question, the options provided, cancer metastasis is really the only one that makes sense based on the scenario they
That
give and the options provided. Yeah.
what are the other things that trip people up in this exactly? I cannot even think of something else that it could be regarding cancer.
Honestly, it's just I can't give you like here's the exact question word for word, and here's all the wrong
Right.
options to not pick. But basically, they just kind of fall for the idea that oh, now this person just has something completely different and unrelated. So instead of kind
Okay.
of looking at it holistically and thinking, what do I have to be concerned about? It's like, okay, now there's this other thing that's completely unrelated. But, so for example, like, now they have bone pain. And so the person says, oh, maybe they have a fracture or something like that. But there's nothing in the question that indicates that the person had an injury or anything like that, but they're giving you this whole history of this organ dysfunction. And now, so, I can't give you the exact choices, like I said, but they're falling for just things like that, things that are completely unrelated or, just don't make sense in the context of all the information.
Got it. Thank you.
Maggie put in the chat box. I mean, I don't want to get too far into that topic because that's taking us in a different direction. But about the soybean, drinking soybean milk for estrogen, there are some people that might still choose to take in some of those plant products to maybe have some effect on their estrogen. But as far as what we're talking about, cancer and stuff like that, there's not a lot of evidence to support that it contributes to that. All right. So, any questions on this handout as a whole, even if, going back to something from last week or whatever? All right. So, the next handout we'll go to is the one on the extraordinary meridians. So it should be labeled it should be from this week's notes. If you go to the folder for class 2, it should be labeled ACU Extraordinary Meridians. That's what we'll go over next. And here we'll break down, the do and the ren, you would have studied for first year, but we'll just do a little recap of that because that's included with extraordinary meridians. But then we'll focus on the chong, the yin chao, the yang chao, the dai mai, etc. So remember what I was saying last week. I had said that the second year comp exam, out of the 60 questions in the acupuncture section, probably three-quarters of them, about 75%, are the same kind of material you studied for first year. Because all those channels obviously still apply, right? You need to know your point locations, you need to know your SUN measurements, you need to know your point functions, your channel pathways, your point categories. All that stuff that you studied from first year still applies. And I mean, that's the bulk of it, right? That's the huge bulk of acupuncture. You got to know that stuff. So, about three-quarters of the acupuncture exam is just the same stuff you studied for first year, and I gave you all those first year handouts and everything. The additional 15 or so questions are this kind of stuff. It's the extraordinary meridians from your secondary vessels class, and it's the auricular. Auricular, we'll talk about next week. But here, let's go over the ren, the du, the chong, the dai mai, and all that stuff. And you'll see that it's actually not that much that you have to know. Like, a lot of times when I talk to students, they're like a little bit paranoid with the extraordinary meridians. They're like, I don't know. I feel like I don't really understand them. I don't really know what I'm supposed to know. The thing is, of course, you can use these channels for lots of things. That's why when you take the class, it's often like a huge list of you can use the channels for this. The comps isn't going to get into like every single, possibility of where you might use the channel. It tends to focus on those things that have an objective correct answer. Things like what's the master couple point? What are the crossing points on the channel? What organs does it enter? It tends to focus on those things that just have sort of an objectively correct answer. So let's go through it, and you'll get an idea here. First off, there's three extraordinary meridians that have a lot of overlap to their pathways: the Ren, the Du, and the Chong. All three of those are said to originate in the uterus. And if the person doesn't have a uterus, then you could just say originates in the lower abdomen. So all three of them are said to originate in that region. And even though there's the primary part of the pathway that most of us are familiar with, like, the Ren runs up the front of the body, the Du runs up the spine, even though there's the primary part of the pathway that we're all just kind of automatically familiar with at this point, remember that they all have internal branches that sort of overlap the others. So, what I mean by that is, even though the primary pathway that we associate with the Du is going up the spine, it does have a branch, an internal branch that runs up the front of the body and basically overlaps the Ren channel. And vice versa. Even though the Ren and the Chong, we think of them as running up the front of the body, they both have internal pathways that enter the spine and overlap the Du to some extent. And then they all have internal branches that go up to the face, wrap around the mouth, and go up to the eyes. So they all have internal branches that do that. So, you just want to remember things like that they all go to the mouth, they all go to the eyes, they all connect to the spine. They all have a pathway that runs up the front of the body, etc. So that applies to all of them. We don't have to necessarily list that individually for each. That applies to all of them. Then also some things that make good test questions when it comes to this stuff is the Du, remember, is said to be the Sea of Yang, the Sea of Yang. And what that means is that we kind of think of it as a reservoir for Yang in the body. So let's say a person has Yang excess. We can store that excess Yang in the Du and basically tap into the Du channel at some point where maybe we need more Yang in other areas. So it's kind of a reservoir for Yang, almost like the lymphatic system is a reservoir for fluids. This is a reservoir for Yang in the body. Also known as the governing vessel. So make sure you know by that name, because sometimes on the exams they'll call it the Du, sometimes they'll call it the governing vessel. The confluent points, that's a term that refers to the master and couple points. Now, technically, confluent points include all point categories, like a chi clef point is a confluent point. But usually this term comes up most commonly in the context of master couple points of the extraordinary meridians. When we're talking about chi clef points, we tend to just say, what's the chi clef point? But in the context of talking about extraordinary meridians, they do sometimes use the term confluent points rather than saying what's the master and couple point. So just most commonly, this comes up in this context. These are really common questions. The test bank has a number of questions about the master couple points. And hope that that's the case. Hope that you get those, because those are absolutely straightforward. You just know them or you don't, right? You don't have to really think much about them. You just either know your master couple points or you don't. And so, I mean, if you've got those memorized, those are easy questions. So the Du, remember, the master point is small intestine 3. The couple point is UB62, so the lateral aspect of the ankle. They're just going to basically ask you, what point is the master point? What point is the couple point? Or more generally, what points are confluent points on the Du or on the Chong or on the Daimai? They're not really going to get into how you use them, because there's lots of thoughts about how to use them. Different practitioners have different methods of using them. You've probably in clinics seen some people where it's like, oh, okay, if it's a male, you start with this side with the master point, and then you do the couple point on the other side, then you do the other couple point, then you do the other hand. Like, and, but not every practitioner adheres to that. That's like one idea. They're not going to get into that because there's lots of different ways of doing it. There's not like one thing that's accepted as right or wrong. So just make sure you know what are the confluent points. So you got to just know DO channel, SI3, UB62, master couple point. Now you can know that broadly, we tend to use the master couple points to activate an extraordinary channel, to activate it, or sometimes they use the term open it. So sometimes people will do the master couple point and then they'll follow it with doing points on the actual channel itself. Or sometimes they'll just do the master couple point. They'll just say, I don't even have to needle points on the channel because I already like opened and activated the meridian by doing the master couple points. Again, there's not really a right or wrong, but just the way people often describe it is they use those points to open or activate the channel. So again, don't worry too much about techniques. Just make sure you know what points are these points. Now the do, I think you all know the pathway pretty well at this point. Again, we already mentioned that there's a pathway that runs up the front of the body and so on, but the main part of the pathway, of course, runs up the spine. And then an important detail is it's said to enter the brain at DO 16, so back here. And then it exits the brain at DO 20 at the vertex. So those 2 points, DO 16 and DO 20, are really important points when you're trying to treat the brain. So if you're actually trying to do a treatment on something that's, maybe from a Western point of view, we think of as a brain disorder, and you're trying to use the DO channel in order to directly treat the brain, those are 2 really key points. And remember that the DO is said to enter 3 organs. So we just mentioned the brain, so that's a key detail. Sometimes you might just get a simple question that says which of the following channels enters the brain? And you want to know the DO is known for that. The DO is also said to enter the heart. So as the internal branch comes up the front of the body, it enters the heart. And there is a little bit of a connection there from Western to Eastern in a way, because, there's a lot of disorders that from a Western point of view, we think of as a brain disorder, or something going on in the brain. It's not always at the level of disorder, but it's something going on in the brain. And from a TCM perspective, we might look at it as a heart pattern because, the Shen is housed in the heart. So the fact that the DO channel enters both of those organs, it kind of makes a little bit of a connection there between, the Western, Eastern in a way. So if somebody has one of those conditions where, biomedically we think of it as a brain issue, TCM wise, we think of it as a Shen disturbance, it kind of makes sense to use the DO because it's linking both of those. And of course, as the DO goes to the spinal column, it enters the kidneys. It enters the kidneys when it's going through that area. So there's basically a connection to these 3 organs. And those are the kinds of things that make for good objective questions. It enters the brain at DO 16. It exits at DO 20. The master point's SI3. It enters the brain, that kind of stuff. These crossing points come up a lot on the extraordinary meridians, but I would say these crossing points on the DO, not as popular as some of the others, because Ren 1, that's not a super popular point to do, but it's one of the crossing points. And UB12, that's, back here in the upper back. So as the DO channel is going up the spine, it hits those points. It hits that point. So you get asked a lot about that kind of stuff in the test questions. And then you might get asked a few questions about, well, why would you use the DO channel? What are some of the common disorders that might cause us to use the DO channel versus using the DIMI or, something else? So I kind of broke it up. These are not formal ways of dividing it, so you don't have to memorize it the way I organized it. But I kind of broke it up into ways of putting this in like little categories, little boxes. So with any extraordinary meridian, you could, of course, use it just to treat like pain and dysfunction anywhere along the pathway, right? So the DO channel runs up the spine. So, I mean, just as, just pure local treatment, of course, you could use it for things like back pain, spinal stiffness, comes up over the top of the head. So, of course, you could use it for things like headaches, stiff neck. Again, that's mostly just using local points. You could say that for any channel. A point that goes over the shoulder area, you can use it to treat shoulder pain. So really no exception with the extraordinary meridians. You could always use it just to treat the pathway. We mentioned it's the sea of yang. So you can also use the do for anything yang related, whether it be excess yang or deficient yang. So essentially, if the person has like low energy, lethargic, that kind of thing, you might want to tonify the do. You might want to like tonify the sea of yang, get more yang released, essentially send a signal to boost the yang. And you could just do tonification techniques. So I mean that's things like needling in the direction of the channel, clockwise rotation, stuff like that. Or in the case of something like excess yang, like liver yang rising, you can sedate the do, like you can needle against the channel flow. You can twirl the needle counterclockwise and so on. So if there's signs of excess yang or yang rushing up to the head, leading to things like dizziness, tinnitus, pounding headache, you might want to sedate the sea of yang or sedate the do. So you can use it for those kinds of things. And then finally, it comes up a lot because it's one of the few channels to enter the brain. It comes up a lot for anything that we associate as a brain related pathology. So, depression, epilepsy, anxiety, anything that, like, by modern science, according to modern science, is such dysfunction in the brain, then potentially you might use the do channel to treat it. And same thing, you can tonify or sedate the do based on the TCM pattern. Based on from a TCM perspective, whether you consider this an excess or deficient condition. All right. So any questions on that? Usually when they ask you about the pathologies, the way they'll phrase the question is they'll give you a list of signs and symptoms and they'll say which of the following meridians or which of the following extraordinary meridians would you utilize or would be the best meridian to treat for somebody with these with these signs. And so like there's always going to be some overlap. There's always going to be other channels that can treat back pain, for example. But they're going to usually give you a handful of signs, symptoms, and like which one, which channel captures all of those. So again, if they're expecting you to say the do, they're going to talk about back pain, spinal stiffness, depression, epilepsy, things like they're going to put all those together. And that would lead you to go like, all right, well, that kind of sounds like the do as opposed to the daimai. Like, yeah, daimai you might use for back pain, but I wouldn't use daimai for epilepsy. So I'm going to cross daimai out as an option. That tends to be how they ask those kinds of questions. So let's go to the Ren channel, the Sea of Yin, also known as the conception vessel. And again, they could go call it either name. So make sure you know both names. Master point, couple point, lung 7, kidney 6. So same kind of thing. You use those points to open or activate the channel. You just want to know those. These crossing points, again, are not as commonly asked about as the other extraordinary meridians that we get to. So the crossing points occur when the channel wraps around the mouth and goes to the eyes. Because do 28, you might remember, is the one that's kind of up in the upper lip, on the frenulum, on the inner, the oral mucosa. And the stomach 1 is up here near the eyes. So it's just as the channel wraps around the mouth and goes to the eyes, that's where it hits those crossing points. Now, as far as, the kinds of pathologies we treat with this is a channel that's probably the most versatile of all the extraordinary meridians. So if you get a question where it lists a bunch of things that are similar, that's seemingly unrelated, and you're like, I don't know, I feel like this could be a little of everything, the answer is probably the Ren. The Ren's the most versatile of all the extraordinary meridians. And the way you could easily remember that is remember all those front mu points that are on the Ren channel. There's all these front mu points to treat a variety of different organs. So as a reminder, Ren 3 is the front mu of the UB. So you can use that for things like urinary tract infection, urinary dribbling, just urination issues in general. The channel we already mentioned starts in the uterus. So it can be used to treat things like miscarriages, fertility issues, discharge, leukorrhea, menstrual issues. I mean, it enters the uterus. So, of course, it could be used for things like that. Then you continue up. Ren 4, you might remember, is the front move of the small intestine. So, somebody had Crohn's disease, for example, Ren 4 might be something to use. Ren 12, a couple of things. Remember, Ren 12 is the front move of the stomach, but it's also the influential point of all fu organs, all your hollow organs. And remember, your fu organs are mostly digestive organs. So Ren 12, between Ren 4 being the front move of the SI and Ren 12 being the influential point of all fu organs, I mean, the Ren channel could be used for a lot of digestive problems. And then, of course, we get up to the chest area. Ren 14 is the front move of the heart. So, any kind of palpitations, chest pain, Shen disturbance, and building on that, Ren 17 in the center of the chest between the two nipples is the front move of the pericardium. And it's the influential point of chi. So, I mean, anything heart related, anything Shen related, you can use these points, and therefore the Ren channel as a whole. Influential point of chi, that usually we think of this as being the influential point of chi because good breathing will help build and circulate your chi. So, right in the center of the chest helps improve breathing. Then the channel passes through the throat. So, throat disorders, voice problems, laryngitis, difficulty speaking, cough. Then Ren 24 remembers up here on the face, plus the channel wraps around the mouth and goes to the eyes. So we could use it for facial issues like Bell's palsy, problems with the lips, problems with the eyes, post stroke, where maybe one side of the face is paralyzed, something like that. So the bottom line is the Ren channel, really versatile, can be used for a lot of things. So if you ever do find yourself in a situation where there's not like an obvious answer to you and like, I don't know, it seems like they're listing a bunch of things. If you have to take a guess, the Ren is probably your best guess. And remember again, just like we were saying with the Du channel, since this is the Sea of Yin, it can also be used for like yin deficiency and stuff like that. You may recall kidney 6, the couple point on the Ren channel. That's a really common point for like a chronic sore throat, chronic dry cough, chronic dry throat, hoarseness. I mean, it sounds like this. Kidney 6 is a very common point for that. Any questions on those? And then we go into the Chong. The Chong, known as the Sea of Blood, also known as the penetrating vessel, again, could be called that instead of the Chong. So make sure you know that. Master point, small or spleen 4 and PC6. We already mentioned that all of the Ren, Du, and Chong, they all originate in the lower abdomen or uterus. Then, as this is kind of wrapping around and coming to the front of the body, it crosses Ren 1. Then it goes up to stomach 30, which remember is just above the pubic bone, too soon lateral to midline. Then it goes inward to kidney 11, which remember is also just above the pubic bone, but it's half assumed from midline. And then it crosses a bunch of kidney points going all the way up to kidney 21. Kidney 21 is the point, the last point on the abdomen, right before we go on to the rib spaces. So it basically hits all of the kidney points going up the abdomen. As it's going up, it goes and says hi to Ren 7 kind of randomly. I don't really know why it said to go to Ren 7. It's not like that's a very, major point or anything. And then remember, this channel is said to go up and disperse in the chest. Like if you look in the pictures in Deadman or any of your other texts, it just kind of shows these dotted lines spreading out within the chest. It's said to disperse in the chest. Definitely for these channels, really make sure you study the crossing points because you want to keep in mind for these channels, the crossing points are really critical because those are the only points, right? These channels don't have their own points. There's no Chong 1 and Chong 2. The only points on the channel are crossing points. So you want to make sure that that you know those points because I mean those are the points you use when you want to needle, when you want to do the channel essentially. You use the master couple point or you use these crossing points. And I do want to just mention real quick another term that comes up is you might see the term instead of crossing points, you might see them called coalescent points. Coalescent points. Technically, any point, any of your acupuncture points are coalescent points. Essentially, they're points that you can needle. They're points where you can access the channel. But most commonly, they come up in the context of the extraordinary meridians because, with other channels, they're just the points on the meridian. We don't really need to give them like a special name or anything. They're just the points on the meridian. But in the extraordinary, when it comes in the context of the extraordinary channels, these basically are the points of the channel, but they belong to other channels. So they most of the time we kind of give them this special categorization. We call them coalescent points. So just instead of seeing them called crossing points, you might see them called coalescent points, just to imply like, yeah, I mean they are crossing points, but these are the points of the channel. These are like the only points available to needle.
I have a question, and I we probably don't have time for this. I'm in this class now this term. Very excited about it. But the Chong, I was listening to a podcast, like that Qiological podcast, and it was saying that the Chong is like yin and yang come out of the Chong, and that the Chong is almost like the Tao, or like I guess maybe what I'm asking is that correct? And also like how do we see the Chong? Like what does it mean, I guess?
I think that's one of those things where there are different people that might package their understanding of the Chong differently. So there are people that might say that essentially the Chong passes through the Daimai and it's carrying the chi and the energy of the Daimai. And that's their way of packaging it. That's their way of understanding it. It's not necessarily wrong because, I mean, keep in mind things like the Daimai are nebulous concepts to begin with. So it's not necessarily wrong to like have that type of understanding, but I don't think there's any really, at least as far as I know, I don't think there's any particular source material that says like that is the answer or the one correct way of thinking about it. I think it's just the way some people might make sense of some of these extraordinary meridians. I feel like you could make the same argument for the Ren that it's carrying some of the Daimai energy up to the organs.
Yeah, because
So
if it's specifically the sea of blood, like I feel like blood has more context than the Tao. Does that, you know what I mean? So I guess I'll just see it as that because that makes more sense.
yeah, I mean, yeah, I wouldn't get too caught up in that because certainly it's not going to come up on comps. So it's, I don't want to get too far in, going in that direction. It's certainly not something that's going to come up on comps, but yeah, I think with a lot of things like that, just keep in mind, like there's a lot of very nebulous concepts in TCM, and then they of course get blended with other Eastern philosophies that aren't necessarily TCM. So then you get gurus that are trying to connect them a little bit. So they're trying to take like Taoist or Buddhist principles and connect them to the idea of channels, but then they also link them to the chakras, and they also, and you have people that come up with these various concepts, and it's some of it's just their own thing, their own interpretation, rather than something where there's any one source to say that that's like the correct answer.
Okay. And then I guess like penetrating this term, that also relates to blood because blood kind of moves kind of throughout every system in the body. Is that the idea behind that name?
I think you could think of it that way. I mean, but again, you could also say that like all the channels and chi like spread through every system in the body. So I mean, I think you can make an argument for, well, then why isn't this other channel referred to as the penetrating vessel? So I wouldn't really worry too much about that. Again, for that'd be maybe a question for like when you get to a Shanghai moon class or something like that, where there's more time to go into some of these more nebulous concepts and, you know, talk about the history of the understanding and everything. Because I mean, these are just the kind of things that are not going to be on comps at all. Yeah. Mm. All right. So as far as how we use this channel, the well, first, of course, like we said, you could always use a channel for any kind of pain, dysfunction along the pathway. So, since this channel runs up the abdomen, of course, you can use it for abdominal pain, abdominal distension, various things like that. It runs up to the chest, and we talked about how it disperses in the chest. So, certainly, you can use it for any kind of chest pain, chest tightness, including what one might experience like during an asthma attack or something. You could also use it for the chest pain, chest tightness that somebody might experience during an anxiety attack or a panic attack. And remember that there's this concept called running piglet chi that exists in TCM, where the idea is that like a running piglet that's running around haphazard, the idea is that the chi is running around haphazard and it's leading to feelings like, you know, butterflies in the chest and shakiness in the chest. And, the idea is that the chi is not well grounded, not well anchored. It's running around haphazardly. They call it running piglet chi. And the chong is one of the meridians that's often used to sort of anchor and harness running piglet chi. If you look actually at your point functions for stomach 30, one of the functions is to subdue running piglet chi. And you could almost literally think of it like picture like needling stomach 30, and that's sort of drawing the energy back down to the abdomen, and that could certainly connect with the idea of like pulling it back down to the dantian. You could certainly connect it to those kinds of concepts where, somebody might then, expand on that. They might write a book and expand on that a little bit. So kind of go into Julia's point, some of those questions. So but as far as comps go, they're just going to say things like which channel could be used to treat chest pain, asthma, running piglet chi. They're just going to present it more straightforward like that. And then, of course, as we said before, sea of blood. So almost anything blood related, you can use the chong for. So if somebody has irregular menstruation, dysmenorrhea, if they have some kind of just general blood deficiency pattern, blood stasis pattern, really anything having to do with blood, since this is the sea of blood, you can use the chong as part of the treatment. Again, it could be part of your treatment. It doesn't mean it has to be, the only set of points you do. Maybe you do some liver points as well, but you can incorporate a chong treatment. And again, incorporating a chong treatment just means maybe you're doing the master and couple point. Maybe you're doing some of these coalescent points like stomach 30, maybe some of these kidney points. Again, doesn't mean it has to be the only points you use. All right. Any questions on that? Then we get to the daimai. So GB41 on the lateral aspect of the foot. Sanjiao 5, too soon proximal to the wrist, right here, master couple point. This channel, definitely you want to know the points along the channel, because this nice simple one. This channel is set to start in the region of liver 13, and you may recall that liver 13 is just below the free end of the 11th rib. So it's said to start in that region. Liver 13 is not typically considered to be a crossing point. There might be some sources that talk about it like it is a crossing point, but most sources don't call it, don't refer to it as a crossing point, but the channel said to start in that general region. And then it wraps horizontally, and it's going to cross 3 gallbladder points on each side. It's going to cross gallbladder 26, 27, and 28. And all of those are kind of in the lower abdominal hip region. So GB26, you might remember, is lateral to the umbilicus. It's level with the umbilicus, and it's, out kind of in line with the free end of the 11th rib. And then gallbladder 27 and 28 are kind of down there near the ASIS, down there in the pelvic region. Or, yeah, pelvic region. So it's going to start free end of the 11th rib. It's going to hit those three crossing points on each side. And then, the free end of the 11th rib region on the other side. And it's just going to go around horizontally. It's the only channel that wraps horizontally around the body. And sometimes just very simple questions like that come up, like what's the only channel in the body to wrap horizontally, to run horizontally and wrap around the body? Which of the following points is a crossing point on the diamide channel? And maybe GB27 is the answer. Where is the diamide channel said to begin? Free end of the 11th rib or near liver 13, something along those lines.
Do you use these at all in your practice?
The extraordinary meridians?
Yeah.
Yeah. Yeah. I mean, really, it depends, right? It depends what you're treating. I mean, of course, but certainly if somebody, the diamide channel specifically, lots of people have low back pain, right? And the diamide, one of the things you could use it for is low back pain, hip dysfunction. So the diamide, I would say, comes up a lot, for that kind of stuff. And certainly, the Ren and the Dew. I mean, you use those for 100 different things. Certainly use those. When it comes to the ones that come up later, the Yin Chow, the Yang Chow, not my go-tos as much. Not hating on them or anything, but just personally, it's like this. Not the channels that kind of tend to pop in my mind the most. But the first four, anyways, I would say I use fairly frequently. Now, as far as some details about the disorders that are treated. So again, you could always use a pathway. So this wraps around the low back, around the abdomen, kind of goes to that ASIS region, runs kind of nearby the hip joint. So anything related to those, hip pain, back pain, particularly lower abdominal pain, hernia, kind of anything going on in that region, you can certainly use diamide points. And also another way to think about this is tightening the belt. So if somebody has hernia, basically means that something is pushing through an opening that it shouldn't be pushing through. So like, an part of the intestine is pushing through the inguinal canal, right? Prolapse, leukorrhea, that stuff coming out from the lower orifice that maybe shouldn't be coming out. So you can use this channel to treat things like hernia, leukorrhea, prolapse. Almost picture it like you're tightening the belt, and stuff that was leaking out, by tightening it, you're preventing it from leaking. So therefore, you can use it for those kinds of things: discharge, prolapse, anything along those lines. Excess menstruation, even. And then, of course, since the entirety of the channel is basically gallbladder points, right? The master point's a gallbladder point. The only crossing points on the channel are gallbladder points. There's a lot of overlap between using the diamide and just using the gallbladder channel. So there is a lot of overlap, and you therefore can use diamide points in treating just general gallbladder disorders. So like temporal headache, for example. I mean, keep in mind, GB41, that's a really common point for temporal headache. You may not think of yourself as like, oh, I'm using the diamide channel, but again, there's overlap. If you're needling GB41, sort of indirectly, you're stimulating the diamide because it is the master point. So we can use these for things like temporal headache, things like liver qi stagnation, gallbladder stagnation in the gallbladder channels, so hypochondriac pain, any kind of like literal gallbladder disorder, any kind of hepatobiliary disorder like gallstones. Remember, gallbladder goes with the wood element. So that really comes up a lot with arthritis, joint pain. So, any number of those things you could potentially use this channel in association with. Sometimes people even use this channel energetically if somebody has a pain where the sensation feels like it's wrapping around the body in some way. Like even if it's not down there in the area of the diamide channel, like for example, they have a headache where they're like, it feels like a band is squeezing on my head. I feel like my whole head is, something squeezing it. Sometimes people use the diamide channel for something like that because the idea is like energetically, it's the only meridian that wraps horizontally. So it sort of corresponds to that kind of sign or symptom.
Is the term daimai, it also means the extraordinaries. Is that correct?
Well, mai means channel in general, right? Rumai,
Right.
like all those. And does dai mean extra? Because it
I
could be a
thought you were
different
referencing
character, even though it's
earlier.
been. Oh,
Oh, okay.
I didn't say that earlier. I don't think.
Oh,
Yeah.
okay. Yeah, I was
Um,
confused. Okay.
yeah, I'm trying to look. Is there somewhere up here that I said? I don't think I said anything about
No,
die
I was
referring
just
to
confused, I
extraordinaries in
think.
general. Okay. Okay. All right. So that'd be the Daimai channel and some key things to know about it. And again, if you know the stuff here, I mean, there's of course with any of the stuff we're going over in the review class, there's more to know. Like we have 5 classes to kind of review everything. So this class is not intended to be going into every detail and the end all be all. But as far as comps goes, if you know some of these key details, you should be able to get the majority of questions, more than enough to pass correct on comps, because comps really does just focus on the things like that are sort of objectively correct. Master point, couple point, here's the crossing points. You could use it to treat back pain. I mean, just things like that that are indisputable. That like any source kind of backs that up. All right. Any questions there? All right. Well, it is 2:15. So why don't we take a break? Let's take we get 18 minutes for a 3-hour class. So why don't we take a 9-minute break, split it up into two, and then we'll continue. We'll finish up these channels and then we'll go into the cardiovascular system for the bio stuff. So take 9 minutes, everybody. All right, y'all, let's continue. Does anybody who's here have any questions on anything so far? All right, let's go then to the Yang Chao, the Yin Chao, and then the Yang Wei and the Yin Wei. All right. So these are probably the four meridians that people probably most likely feel the least confident with, because I would say, they maybe come up in the extraordinary vessels class. They're mentioned as, a bunch of things they can do. Probably don't get as much reinforcement with these in clinic. And, but realistically, you have a lot of avenues for treatment in Chinese medicine, and just not everybody's going to use everything. But as far as, again, as I mentioned before, for comps, the questions tend to be pretty straightforward. Big objective things, master couple points, crossing points, and the primary things we use the channel to treat. So the Yang Chao, also known as the Yang motility vessel, and definitely remember it's known as the Yang motility vessel because that's kind of a key thing, because most of the things that we use the channel to treat are related to motility. They're related to things like muscle imbalances, joint dysfunction, stuff like that. So we tend to use the yin chao, which is the yang motility vessel, and the yang, sorry, did I say, I think I flipped it. The yang chao, the yang motility vessel, and the yin chao, the yin motility vessel, usually together. Usually it's about balancing them out because, essentially they're on opposing sides of joints typically. One's running up the lateral side of the leg, the other's running up the medial side of the leg. So when we see, that maybe there's a muscle imbalance, that like the hip joint is turned externally or something, the idea is the yang chao is too tight, the yin chao is maybe too weak. So oftentimes we're needling both. We're sedating the yang chao to loosen up those muscles, maybe tonifying the yin chao, the opposing group, to strengthen up those muscles. So often they're used together. They're using, to balance each other out. Notice the master couple point. They're the reverse of the do. So the yang chao, the master couple point, is just the reverse of the do. So the master's UB62, the couple's SI3. So there's really only 4 channels that you have to memorize the master couple points for, and then just know that the remaining 4, they're just flipped. You just have to remember which channel is the flip of which one. So yang chao goes with the do here. Yin chao, notice that's the reverse of the ren. Now the pathway, the yang chao has a lot of points. Mostly we're talking about the lateral side of the foot, the lateral side of the leg, running up the kind of the low back area of the body, and then coming onto the shoulder, but mostly this channel is kind of running up the lateral aspect of the body. So it begins at UB62, which is the lateral aspect of the ankle, goes down to UB61, which is also around the lateral aspect of the ankle joint. Then it ascends up the lateral side of the leg and up to the torso. Along the way, it's going to cross UB59, the cheek cleft point, and that's going to be down there in the lower leg. Then it'll cross over the knee. There's not necessarily a point in that area that it crosses, but it crosses over the general area of the knee joint. Then it's going to come up to the region of the hips, where we're going to cross GB29. So notice, again, it's the motility vessel. And there's a lot of joints we're crossing. We're crossing the ankle joint, the knee joint, the hip joint. Then it's going to travel up the low back area and then onto the upper back. And it's going to hit back here, small intestine 10. So now we're in the area of the shoulder joint. So we're going up kind of along the back. So it's good for issues like that. Issues of any of the joints of the lower extremity, ankle, knee, hip. Now we're in the shoulder area. And then from SI10, it runs over to LI15 in this area, also shoulder. LI16, it doesn't matter if you can see exactly where I'm pointing. The point is just that, like, a bunch of shoulder points. Then it goes up the lateral side of the neck and goes to stomach 4. So that's on the corner of the mouth. Then it hits stomach 3, somehow skips stomach 2. It's one of those weird things where it goes to stomach 4, hits stomach 3, somehow skips stomach 2, but goes to stomach 1. So now we're getting into the eye. Then it goes over to UB1, so also in the area of the eye. Then it crosses over the head to gallbladder 20 back here. And from gallbladder 20, it's said to enter the brain. It's said to go into the brain. So there's a lot of points that are crossed. But one of the major themes of this channel is it's crossing a lot of joints. So hence the idea of being the motility vessel can help correct a lot of muscle imbalances and joint dysfunction. It goes to UB1. So you might remember this channel is used to regulate the opening and closing of the eyes. So we could use it to treat, things like sleep dysfunction. And then it's said to enter the brain. So we also can use it to treat disorders involving the brain. All right. Now, there's a couple points on this channel that the yang wei also crosses, and you could get a question that says something like the yang chao and the yang wei both cross which of the following points. So make sure that you know small intestine 10, which we mentioned, the yang wei that we'll get to down here also crosses that point. And GB20 that we mentioned back here, the yang wei also crosses that point. So a little bit of overlap on those two channels. So this is a tougher pathway to remember because again there's a lot of points, and the yang wei channel when you scroll down here also has a lot of points, so it's easy to confuse them, to flip them. So that's just something you'd want to devote a little bit of time to, remembering which points are on which channel, particularly not confusing the yang chao and the yang wei with each other. Yeah. But as far as what we use the channel for, like why would you choose to do these points as opposed to other points? Pretty straightforward for comps purposes. Again, mostly think motility related, joint dysfunction, muscle imbalances. So typically we needle these points when there's tightness on the lateral aspect of the leg. So, the lateral aspect of the thigh, if those muscles are tight, the lower leg, the peroneal muscles, if they're tight, if that's causing the foot to be turned at an everted angle, or the hip, the whole hip joint to be externally rotated. In other words, the whole leg's like turned outward. The idea is those muscles are too tight. So you want to needle those yang chao points. Same thing, the back muscles. This runs up along the hip, then it runs up along the back to go to SI10. So if you've got tightness, spasm in the back muscles, that might lead to, low back pain, tightness in the low back, etc. Again, you might use these points, this channel. Again, motility related. And certainly it crosses over the shoulder. So you can use it for, shoulder problems. You can use it for people that have where their shoulders are rounded forward, in order to correct postural imbalances. So you can use it for, anything like that, correcting any kind of postural imbalance. Typically, you'll want to needle in a sedating fashion into the points on the side of the tightness. Then remember this channel, because it crosses UB1, it's said to be used for things like insomnia. The idea is it's the yang chao. So there's too much yang energy going to the eyes is the idea. So the person develops insomnia. One way of phrasing it is like they can't close the eyes. They can't keep the eyes closed. It doesn't literally have to mean they physically can't close the eyes, but it's just kind of a way sometimes of phrasing, that they have insomnia. They can't keep the eyes closed. They can't relax. They're too alert. So we sometimes use this channel for that purpose. And again, we'd probably be sedating. We'd likely be needling in a sedating fashion. If the person had insomnia, and the idea is too much yang energy is going up to the eyes. And lastly, brain disorders. Most commonly, this comes up in the context of epilepsy. A lot of times it doesn't even really specify daytime or nighttime, but some sources you might see it said that it's said to treat daytime epilepsy, because daytime is the yang time of day. So the idea is if there's too much yang chao energy going to the brain, and now it's the yang time of day on top of it, that might exacerbate it. But again, a lot of times when it comes up on tests, it doesn't even specify time of day. It just basically says, gets into the fact that this channel can be used to treat epilepsy. And it doesn't even have to literally be epilepsy either, just having seizures, because not all seizures necessarily are epilepsy. So it can treat those kinds of things. And again, if you know that kind of stuff, you should be good. You don't have to know every possible thing that we could justify using this channel for. Just know some of these key things and you should be fine for comps. Any questions on that? Then if we compare it to the yin chow, the yin motility vessel, remember the yin chow basically is running along the opposing muscle groups, along the opposing side of some of these joints. So the yin chow, the master couple points, is the reverse of the ren, kidney 6 and lung 7. It starts at the medial aspect of the ankle as opposed to the lateral aspect. So kidney 6. So it actually starts at the master point here. It runs up the medial side of the leg, crossing kidney 8 in the lower leg. And then you just kind of have to imagine an invisible line running all the way up from kidney 8, up the medial side of the leg, onto the abdomen, alongside the genitals. Well, first the genitals, then onto the abdomen, then eventually coming up the front of the neck, going onto the face, going to UB1, and then entering the brain from there. There's no other crossing point. So you just kind of imagine an imaginary line going straight up from the medial aspect of the lower leg, just kind of straight up the abdomen to UB1. So mostly these are on the channel is going to be running along opposing muscle groups of what the yang chow did. It's going up the medial part of the leg, the medial side of the knee, the medial part of the hip joint, the abdominal muscles as opposed to the low back, near the anterior aspect of the SCM as opposed to the lateral aspect, then onto the face, and so on. So typically we use this channel for the opposite problems. If the medial aspect of the leg, if those muscles are tight, spasmed, the foot is inverted, the hip joint is internally rotated, you also could use this to treat back pain because back pain could be related to both abdominal and low back muscles, just any kind of imbalance between those. So you might also use this channel to treat low back pain. You can use it again for people that have like the rounded shoulders. If these muscles are too tight, it could pull the shoulders in an anterior direction. So you can use it for that kind of thing. If too much yin energy is going to UB1, the idea is the person has hypersomnia. They can't keep their eyes open. They want to sleep all the time. So you can use the yin chow, basically sedate that yin energy for treating hypersomnia. And then same kind of thing. You could use it for epilepsy, and you tonify, sedate the channels kind of accordingly to the pattern the person has. So again, sometimes here it might specify that they have nighttime epilepsy. The idea is if it's a yin chow dysfunction, that shows up more during the yin time of the day. Now, again, in your classes, you can go into more in clinic, you can go into more detail of like, exact treatment methods and things like that and ways to put this into action. The comps just doesn't really get into that though. The comps usually just kind of lists certain symptoms, certain indications, and says what channel would you use. So as long as you basically recognize like tightness on the medial side of the leg, inverted foot, hypersomnia, as long as you basically recognize that goes with yin chow and the opposite goes with yang chow, you'll be fine as far as comp questions go. And that's our only real job here, is to make sure we cover what you need for that. One thing I want to highlight is, I've already said, make sure you know your crossing points on these channels in general, since the crossing points basically are the only points. There are no yin chow specific points. So you need to know the points that you use to treat the channel. One thing that sometimes comes up that confuses people when they get questions about the about point categories, sometimes you'll get questions that are phrased, which of the following groups of points are all chi clef points? And then option A will list 4 points, option B will list 4 points, and so on. People often forget about the chi clef points of the extraordinary meridians. And sometimes well, it used to be when I was physically in the classroom, somebody would come up and like show me the test. Now sometimes they fill it out on the comment cards. They'll say, oh, for question number 50 or whatever, there was no correct answer. Each one of those included something that wasn't a cheek left point, and what the person was overlooking was the cheek left points of the extraordinary meridians. So they're thinking kidney eight's not a cheek left point. That's not the cheek left point of the kidney channel. That's like, you're right. It's not the cheek left point of the kidney channel, but it's the cheek left point of the yin chow. So make sure you don't forget those.
Did you have like a system for how you memorize all the categories for the points?
I mean, some of them, there's just rules to remember, right? Where you don't really have to memorize the points per se. Like, the well point's always the most distal point, the spring point's the second most distal, the source points are always the third one up on yin channels, fourth on yang. So, right, there's certain ones like that you just, you don't really have to memorize. As far as the ones that you do, like the Luo point versus the Chi Clef versus the Jing River, to be honest, there really isn't some system that's just going to like make it stick across the board for all people. I mean, at least nothing that I can think of, because it is kind of random, right? It's like there's not necessarily a certain order to them. They're not always the fifth point or the sixth point. It really is just straight memorization. But what I did really was just like, I just committed one day. Like I remember doing this. There was a time where I was studying for whatever it was, points two or something. And you know how it is with your points classes where you're learning new channels, but then you're also held responsible for the prior channels. So there was stuff that like I knew I had already studied for points one, but now it's going to be on this points two test. And so I'm going over it, and you kind of eventually get to this point like, oh my God, like I keep forgetting these. I've studied this, every term I'm having to review what's the cheek left point, what's there was one day where I just sat down and I just went over it literally again and again and again, to the point where it just stuck. Just like, you always remember your grandfather's, well, if you grew up before cell phones, you may still to this day remember your grandfather's phone number or some phone number like that. It just sticks because you dialed it so many times. And eventually I just got to that point where it just stuck. Now I
I
just
know
know it.
some people like they'll memorize the whole chart, and they'll, before any test, they'll just write out the whole thing of like every category of every channel. That's not how I do it, but I was just wondering if everyone has a different way that they learn and
Yeah, no,
memorize.
no, I don't do that. Like I know some people, they'll write out, like you said, like a little graph on a scrap piece of paper, and they just kind of remember that it's like, just making something up, that it's 4732, and then the next one's like 8765, and then like they just have a certain system where they just memorize that. But to me, that's like you're just doing rote memorization of numbers, and then when you actually have a patient in front of you, and in the moment you have to be like, oh, I want to needle the cheek left point of this channel. It's like, what are you going to do in your mind? Okay, so that's 1 7. So for me, I'm just like, ultimately, you want to just know this when you have a patient on the table and you're needling. So I just one day sat down and I'm like, I'm just going to go over this again and again. And for me, it helped reinforce it to like point to the point and think of it as like, okay, that's the cheek cleft point. So like if I had pain throughout the channel, I would want to use this. If it moderates acute conditions. So if I had these kinds of conditions like an acute injury or an acute infection, this is be a point I would use. And I would just sort of like keep doing it like that. I just kind of devoted one day to just like again and again and again drilling it until I eventually just like they were just in there forever. I don't know, that worked for me. And I like that. I think everybody's different when it comes to stuff like that. So there is no like one way that's going to work across the board that everybody's going to remember. Just, just to me, it's repetition. All right. And the last couple channels, as far as the extraordinary group goes, then we get to the Yang Wei, also known as the Yang linking vessel. Master point is the reverse of the Daimai. So the Daimai is basically considered to be a Yang channel. So it's the reverse of the Daimai point. So the master couple point, Sanjiao 5, GB 41. The reason this is called the linking vessel is because it's said to link, to connect to all your other Yang meridians. And you can see that that's basically true if you look at the points that are listed as crossing points. It starts at UB63, which is the lateral side of the foot, goes up the lateral side of the lower leg where it crosses GB35, the cheek cleft point of the channel. So, okay, we've crossed the UB channel, we've crossed the gallbladder channel, continues up the lateral side of the body, and it's following a very similar path to the Yang Chow. You know, it's hitting slightly different points, but it's basically going up the lateral side of the body. Then it goes to SI10. Remember, we mentioned the Yang Chow also crosses that point. So now we've crossed a third Yang channel, the small intestine. Then it crosses over the posterior aspect of the shoulder, hits Sanjiao 21 up here, and or sorry, Sanjiao 15 and gallbladder 21. So we had already mentioned the gallbladder, but now we cross the Sanjiao. So that's a couple points up here. Then it goes up the lateral side of the neck to the face, to stomach 8. So again, the same basic pathway as the Yang Chow, but slightly different points. Well, now we're crossing the stomach channels. That's another Yang meridian we've just crossed. Then it's going to go to gallbladder 13 and hit every gallbladder point all the way back to gallbladder 20. So this channel's mostly gallbladder points. The majority of points are gallbladder points. Then it goes to do 16 and do 15. Remember the Sea of Yang. So the Du channel, another Yang meridian. The only channel that's not represented here is there's no LI points. There's no large intestine points. That doesn't mean that it doesn't cross the large intestine meridian. It just doesn't do it at a particular point, at a particular acupuncture point. But you can see that represented, that it basically links all the Yang meridians together. So what do we typically use it for? There's kind of two ways to think about it. You can use it if you're treating a condition where there's multiple Yang channels or Yang organs involved, and you just kind of don't know where to start. You know, so somebody maybe has pain and it's involving like a large region of maybe their leg and low back, and you're like, well, I don't know. It seems like the UB channel's involved, the gallbladder channel, but they also have pain in the back of their legs. All right, that's more UB again. And there seems to be multiple Yang meridians involved. And you're just kind of like, all right, well, I don't really know where to start. They also have pain in their arms. So, all right, that's now where it's getting large intestine, small intestine meridians. So, if you're ever in that kind of situation, the Yang way might be a way to go because it links all these different channels and therefore can encourage, you know, better flow of qi within a variety of channels. So, you can use it for those kinds of things. And also remember, your Yang meridians in general are more superficial meridians. They're more on the surface relative to yin channels. So external attacks more commonly involve Yang channels. So this channel is also commonly used for somebody with an external attack. Yeah, like fever, chills, floating pulse, that kind of thing. You know, notice the master point, Sanjiao 5, that's a very common point for external attacks. Again, you may not think of yourself as like, oh, I'm treating the Yang way, but if you're needling Sanjiao 5, I mean, you are kind of indirectly activating the Yang way. So again, a very common point for external attacks. So devote a little bit of time to committing some of these crossing / coalescent points and memories, particularly making sure you don't confuse Yang Chow and Yang Wei, because they both have a lot of points. They kind of run close to each other, but they're slightly different points with a couple of exceptions. There are some points in common, but it's easy to confuse them. And then lastly, the yin wei. These points, the master couple point, are the opposite of the Chong, like for a second. PC6 and spleen 4 are opposite of the Chong. This channel is said to start at the medial aspect of the lower leg around kidney 9, which is the cheek cleft point, runs up the medial side of the leg to the front of the abdomen. And then these points are pretty easy to remember. Like, even though there's a few of them, they're pretty easy to remember because look at the numbers. It crosses spleen 12, spleen 13, spleen 15, spleen 16, and then liver 14. Now, that's the order the channel hits those points. But if you look at the numbers, 12, 13, 14, 15, 16, it's just nice that it kind of works out that way. So this is the order it hits the points. So it hits the 4 spleen points first and then liver 14 after that. But as far as remembering which points, which numbers, it's pretty easy, I think, to remember 12, 13, 14, 15, 16. You just have to remember one of them as a liver point. Then it continues up the abdomen, you know, in the rib area, up the abdomen. And then it's going to go to Ren 22 and Ren 23. So 2 points on the throat. And that's where it stops. So one thing that sometimes comes up about this channel is that this is the only channel other than the daimai. Of the extraordinary meridians, this is the only channel other than the daimai to not go to the face. It just stops at Ren 23. So hopefully it's obvious the daimai doesn't go to the face. This is the only other extraordinary channel that doesn't go up to the face. And here, this does the same thing, just the other side of the coin of what we were saying for the yang wei. It's the yin linking vessel, so it's said to link all the yin meridians. So same kind of thing. If you have something that's involving multiple yin channels, multiple yin organs, and you're not quite sure where to start, one way to approach it is to treat the yin wei vessel. Most commonly, it comes up for chest pain related to the heart, the chest area, because if you think about it, that's where a lot of your yin organs and therefore yin channels that go to those organs kind of meet up in that area. I mean, just think about it, right? Center of the chest, you got the heart's surrounded by the pericardium, so that's also the chest. Just lateral to that, you have the two lungs. Just below that, on the right side, you got your liver. Just below that, on the left side, you got your spleen. And then if you go around back a little bit, you've got your kidneys. So kidneys are a little bit out of the way there because they're more on the back side. But all those organs are kind of like meeting up in that area. And of course, the channels all, connect to their organs. So yeah, if somebody had like just general chest pain and it's not really clear, is it this channel, that channel? They're just coming in with sort of this broad, sense of chest pain. Well, this might be one way to approach it, as opposed to like, I don't know, I'm just going to do every channel. All right. Any questions on that? This handout as a whole, this topic as a whole. All right. So yeah, take a look at that. I mean, honestly, second year comps, I think, are very straightforward. You got to go, Maggie. All right, good seeing you again. Enjoy class or wherever it is you
Yeah.
have to run to.
I have the little lab.
Oh,
See you
gotcha.
next week.
Enjoy. See you next week. Or well, no, not next week. I think we have next week off, so we
Oh,
meet
yes.
again week 4.
Okay, good. Have a good one.
You too. See you then. All right. So yeah, take a look at this. So basically, at this point, you really have, just to give everybody an idea where we're at, like you really have at this point all of the handouts, all of the key underlying material for the Chinese medicine section, because that's all the same universe of materials first year comps. Gave you all that the first day, and we kind of went through it. But that's all stuff to just kind of review again what you reviewed for first year. There's nothing new to go over. Acupuncture, if you look at those handouts and stuff that are relevant to first year that you already studied, you already passed, and you add what we just went over, you pretty much, that's all the acupuncture section. The exception is a little bit of auricular that we'll cover next time. So we'll go over that next time. But you kind of have all the key materials at this point. That's why you can really study the bulk of what's on COPS. Like you already have it all. Law and safety, you already have a handout that summarizes the key things for that. There's only 10 questions. Bio has a lot of extra stuff, so that's why we'll hit on that a little bit. But you already have a lot of the key material to really get going on this. It's just a matter of giving yourself enough time to download it into the memory banks. So now let's go back to the biomed topic, and let's talk about the cardiovascular system. And we'll talk about a little of everything here. We'll recap some of the key anatomy physiology. We'll go over any disorders, like any pathophys that applies, and we'll go over within this any pharmacology that applies. So first, remember the heart's located in the mediastinum. That's the area in between the two lungs. So just broadly speaking, that's the cavity, that's the space that we find the heart located within. And here for the heart drawing, I mean, the reason it's written like this is because, it used to be the case where physically in class, I draw it on the board and remind people of this. But now I just give you the picture that I give out in my AP3 class. So you may remember this if you had me for AP3, you may remember a drawing, somewhat like this. What we're saying is you don't have to know this exact drawing, obviously, because it's not like an anatomically correct representation of the shape of the heart or anything, but you need to know what this picture is conveying. So you need to know things like the superior vena cava, the inferior vena cava, the coronary sinus bring deoxygenated blood to the right atrium. That's why they're written in blue. That's why right atrium is written in blue. These are carrying deoxygenated blood into the right atrium. Then you need to know that there's a tricuspid valve that separates the right atrium from the right ventricle. Remember, it allows blood to go from the right atrium down to the right ventricle, but then it seals, hopefully, to prevent backflow. So this valve between the right atrium and the right ventricle is called the tricuspid valve. You do get questions about what valves are located in what area, what blood vessels take blood to this chamber or away from that chamber. Is it oxygenated blood or deoxygenated blood? Those are the kinds of things that you need to know. So then the right ventricle pumps the blood out through the pulmonary valve. It then goes into the pulmonary trunk, which splits into right and left pulmonary arteries. And remember, this is taking deoxygenated blood to the lungs for the purpose of getting oxygen, right? That's why we're sending it to the lungs for the purpose of picking up additional oxygen and reoxygenating that. You want to remember that the pulmonary arteries, they're a little bit of an exception to the general rule. Remember that generally speaking, arteries have oxygenated blood. The pulmonary arteries are the exception to that because these arteries are taking blood from the heart to the lungs for the purpose of getting that oxygen. So they're an exception to the general rule. Generally speaking, arteries are taking oxygenated blood to your organs and tissues. The exception to that is the pulmonary arteries. And if the blood goes through the pulmonary valve on the way to the pulmonary trunk and such. Now the blood gets oxygenated as it passes through the lungs. It basically picks up the oxygen we're breathing in, and it returns to the left atrium of the heart, now newly oxygenated. That's why it's all red. So it returns via the pulmonary veins and comes back to the left atrium here. And again, the pulmonary veins are, again, the exception to the general rule. Generally, veins are taking deoxygenated blood from your organs and tissues back to the heart. Remember, the pulmonary veins are carrying oxygenated blood because this is the blood returning from the lungs after it just picked up oxygen. So the pulmonary veins are an exception to the general rule about veins carrying deoxygenated blood. Mm-hmm. So now this newly oxygenated blood is in the left atrium. It passes through this valve that can be called the bicuspid valve, but more commonly it is referred to as the mitral valve. Then it goes down to the left ventricle, and then the left ventricle pumps it out through the aortic valve into the aorta. And then from the aorta, it branches out into arteries that take oxygenated blood to all your organs and tissues throughout the body. So you want to make sure that you know those kinds of things. You want to know like what blood vessels take blood to the left atrium, the pulmonary veins. What blood vessels take blood from the right ventricle to the lungs, the pulmonary arteries. Do the pulmonary arteries contain oxygenated or deoxygenated blood? It's deoxygenated blood.
So potentially this is like a study tool, like that functions like a clock moving. Like you're basically telling me chronologically what's happening.
Yeah, I was just going through the
Kind of.
sections, like following the blood flow. So I was following the
Right.
blood flow into the right atrium and then everywhere it goes through and labeling
Yeah.
some of the key landmarks. So yeah, if you know that stuff that we just went through, you'll be able to answer any questions on the exam that come up. So yeah, they'll ask questions like that. They'll ask like, what's the name of the valve that's located in between the left atrium and the left ventricle? And you've got to know, oh, that's the mitral valve. as opposed to the pulmonary valve, for example. What blood vessel takes deoxygenated blood back to the right atrium? These three. So any one of these or all three of these. So make sure, again, you don't have to know like this exact picture in the sense of like drawing it the way I did or anything like that, but you need to understand the information it's conveying. So as long as you got that down, you'll do fine.
Yeah, I just remember trying to study this for Comp1, and I had really terrible AP teachers, like most of them in New York, and never really learned this stuff. And there's a lot to know about the heart.
Well, why didn't you
So,
take AP with me then?
darling, I heard all about you from New York, but I couldn't get in there for some reason.
Well,
Maybe I
it's a lot,
was too young.
a lot of competition to get into my class.
I
No,
know. Believe me, I would have killed because
oh,
now I'm
joking.
like catching up. Comps 2 trying to I basically had to teach myself a lot of this stuff from like crash course. But there's just a lot to know about the heart, so I was like, I don't know where to start and stop. So anyways, yeah, if I can just get this like the
Yeah.
order of operations down, it sounds like that'll be okay.
Yeah, I think this will help you in terms of, where to start and stop because essentially as far as the basic heart anatomy and the blood flow through it and the valve, this is a lot of what can come up for the anatomy aspect of the heart. So as long as you basically understand what's being shown here, you should be able to answer most comps questions, even if you still like, there's some details about the heart that are, a little bit confusing. And we'll add a little more detail in the other handout too. So
Yeah. So sorry, you just said this, but these three on the upper left, the superior vena cava, inferior, these guys, you said they're bringing deoxygenated or oxygenated? Oxygenated.
deoxygenated because this is
Okay.
the deoxygenated blood that's returning to the heart from all of the body organs and tissues. So it's returning to the heart. Remember, that's the reason that we have to send it to the lungs to get more oxygen.
Yeah, duh. Yeah, that makes
Yeah.
sense. My brain was like, blue means oxygen.
Okay, so keep that in mind.
That's,
Whenever you're looking at an anatomy text, whenever you're looking at arteries, veins, that kind of stuff in an anatomy text, blue is always used to designate deoxygenated blood, and red is always used to designate oxygenated blood. That's pretty
oh,
standard.
wow. I just literally reversed them. Okay,
Yeah.
great.
All good. Just know, like, yeah, when you're looking at pictures like that, that's pretty standard as far as the labeling goes.
Wow. See, basic things that I should know. Thank you.
Yeah, no problem. And that's why we do this. I mean, you learn a lot of stuff in the program. It's easy to forget things. I understand. And especially if maybe you didn't learn it right the first time, like for whatever reason, the way it was taught, whatever it might be. Yeah, there's a lot to keep track of. I'll say, okay, so a couple other things. The heart sounds sometimes come up. Basically, the questions are just what creates the heart sound. So when you listen to somebody's heart, whether it be through a stethoscope or whether it be like, you're laying down and you hear that boom, 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 boom. Basically, the question comes up is what is that? What are you hearing? You're hearing the closing of the valves. So the first heart sound, and I'm just going to go back to the picture here, is what we call the AV valves, the tricuspid and the mitral valve, the valves located between the atria and the ventricles. So they're called the AV or atrioventricular valves. When these two valves slam shut, that creates the first heart sound, the first boom. And then that's followed shortly thereafter by these valves, the pulmonary valve and the aortic valves slamming shut. Collectively, these valves are called the semilunar valves. When those slam shut, that creates the second heart sound. And again, that's all listed here. S1, closing of the AV valves. We specify which valves are the AV valves. S2, closing of the semilunar valves, and specify which ones are the semilunar valves. Then you just want to have your terminology down, like systole versus diastole. So remember, systole is the contraction phase of the heart. It's basically when a chamber is pumping. Diastole is that in-between state when it's refilling. So sometimes people refer to diastole as the relaxation phase because the muscle's kind of in a relaxed state. Sometimes people refer to it as the filling stage because, that's when it's refilling. Either way, but diastole is the term for that, the more technical term. And then the cardiac cycle, we'll do this and then we'll take a break. The cardiac cycle is basically just it's listing the events of the heart as the blood moves through. So it's all listed here, but I'm just going to go to the picture and point it out real quick just to reinforce this. So if we pick a starting point, like, okay, there's blood in the atria right now, because you have to pick a starting point since the blood's moving through the heart constantly. So the starting point is basically that we have blood in the atria, both atria. So both atria have to undergo systole, they have to contract. So we say that atrial systole occurs. You don't have to specify right or left, just both atria contract. Since the atria are contracting, that pushes blood down to the ventricles. So simultaneously, the ventricles are filling. The atria are undergoing systole, the ventricles are undergoing diastole. As the atria contracts, blood goes down and the ventricles fill. Those things are happening simultaneously. It doesn't really matter what order you say them in or write them in, they happen together. Mm-hmm. So remember, the atria and the ventricles are always doing the opposite of each other at any moment. Both atria do the same thing as each other. Both ventricles do the same thing as each other. Atria ventricles always do the opposites of each other. So if both atria are contracting, that means both ventricles are filling.
What an insane organ.
It
Like,
is.
it's crazy that this is happening every moment.
Well, don't get me started on the brain. I mean, right?
It's nuts. The body is so crazy.
It is. It's true. So those two events happen simultaneously, and then the tricuspid and mitral valves, what we call the AV valves, they slam shut to prevent backflow. So the blood moves from the atria to the ventricles. Then these valves slam shut so it doesn't regurgitate. That creates that first heart sound. Now, basically, we just have to do the opposite of everything we just said. Now we need the ventricles to undergo systole or to contract. So they contract, they pump the blood out to the lungs on the right side, the aorta on the left side. As that's happening, the atria refill. So the atria are said to be undergoing diastole as this is happening. So the left atria is receiving blood from the lungs via the pulmonary veins. The right atrium is receiving blood from the vena cavas and coronary sinus on this side as the ventricles are pumping. And then, of course, these valves, the semilunar valves, slam shut to prevent backflow, and they create that second heart sound. And again, that's all listed here under cardiac cycle. That's the order of events. And now we're just back to our starting point. So we just keep doing this again and again and again, nonstop.
The tricuspid and mitral valves, are they similar structures? They're just named differently because they're in different places? Because if they're both preventing backflow,
Well,
right?
they're similar structures, but the reason they get the different names is the tricuspid valve literally has three flaps, three cusps. So they call it
Oh,
the
okay.
tricuspid, and the other one only has two flaps or cusps. So they call it the bicuspid. But then some people thought it looked like a certain hat that bishops wear that's called a mitre. So they gave it the nickname the mitral valve.
Okay, cool. Thanks.
Mhm. All right. Well, that's a good breaking point. So we've got about an hour left at this point. So we'll take our second 9-minute break and then we'll pick up here and get to where we get to. So let's take 9 minutes. All right, let's finish here with the cardiovascular system. Finish up here. So then a couple other things going from anatomy physiology, a couple of physiology things. There's something called the Frank-Starling law regarding the heart. And you're not going to get asked anything overly technical about it, but you have to at least recognize basically what the Frank-Starling law is. And essentially, there's this concept with the heart that the muscle fibers stretch to accommodate incoming blood. So when a chamber refills, the muscle fibers stretch to accommodate it. And there's elastic fibers built into the tissue. So the more it stretches, the harder it recoils. That's basically the idea, kind of like a slingshot. The more you pull it back, the harder the recoil, and then the further the object will go. So when you put that in a little more technical terms with the Frank-Starling law, basically it's the force of the myocardial contraction is proportional to the degree of stretch after diastole or after the filling phase. So the more the chamber fills, the more the muscle fibers stretch, and that'll lead to a proportional higher recoil. The degree of stretch can just be abbreviated and called the preload. So you could just say the force of myocardial contraction is proportional to the preload. You could just say that, or you could spell it all out. But either way, you should know that like that concept is what we call the Frank-Starling law. And of course, the greater the force of contraction, the more blood that comes out. The more forcefully the blood comes out, the more volume of blood gets ejected because it's a stronger pump. So it results in more stroke volume, essentially. Then remember, the heart is autorhythmic. The heart has its own internal conduction system. So even though the heart can be influenced by the brain, the spinal cord, it can be influenced to beat faster, beat slower based on whether you're meditating or whether you're, stressed, nervous, fearful of something. And you don't require any kind of outside stimulus to the heart in order for the heart to do its day-to-day thing. The heart's autorhythmic. And the reason it's autorhythmic is because it's got this own internal conduction system. So we have these pacemaker cells referred to as the SA node. So we have this node of cells that collectively we call, you could either spell it out called the sinoatrial node or just the SA node for short, or sometimes even just the sinus node. It's all referring to the same thing. This is basically the pacemaker of the heart that spontaneously fires. It spontaneously fires at action potential. And then that action potential spreads through the contractile fibers of the atria. You might remember this goes back to AP3. The reason it can spread through all the fibers is because the muscle cells of the heart contain what they call gap junctions. So the ions spread from cell to cell. It just spreads through the entirety of the atria. So now all of the atrial fibers essentially get that electrical signal to contract. Then there'll be a pause in what we call the AV node. So the AV node is a structure that essentially, as far as the conduction pathway goes, it's a structure in between the atria and the ventricles. And the signal will slow down in there. It will pause. There's very few gap junctions, so it kind of slows down in there. But it does get through, it just a little more slowly. So then it'll go to what they call the bundle of His, which could also be called the AV bundle because it's in the area between the atria and the ventricles. Then it's going to spread into what they call left and right bundle branches. Then it's going to hit these fibers called Purkinje fibers. And Purkinje fibers are known for really fast conduction. They're known for lots of gap junctions, and the conduction signal spreads through them really, really rapidly. And then from the Purkinje fibers, it makes it to the ventricles. This all within the ventricles makes it to the actual like contractile muscle, the contractile fibers of the ventricles. And then the ventricles contract. They get that electrical signal and they contract. So basically, as far as comps go for second year, you want to know just the general concept of the heart being autorhythmic, that the electrical signal that regulates the heart is all generated within the heart itself. It doesn't require like a peripheral nerve to stimulate it. And then you want to know the order of the parts. You want to know that signal starts with the SA node, then it spreads through the atria, the AV node, then the bundle of His. You want to know this order. Those kinds of things can come up. So as long as if you got that stuff down, you should be pretty good as far as this topic goes. Then you may get a basic question about the EKG. The EKG, remember, is the in a hospital setting or in a cardiologist office, they'll put some electrodes around the area of the heart, and these electrodes will read the electrical currents happening within the heart, and it'll create a display that'll show like little waves, little peaks and valleys showing the electrical signals moving through the heart. Now, for comps purposes, you don't have to be able to read an EKG. They're not going to show you an EKG. You don't have to be able to analyze an EKG to decide if a person has a certain heart condition or anything like that. You just need to recognize the three main waves and know what they represent. So as long as you know what's here, even if you have no idea what it means, as long as you know that P wave is atrial depolarization, the QRS complex is ventricular depolarization, and the T wave is ventricular repolarization. As long as you basically know those three things, even if you have no idea what that means, you just know P equals this, QRS equals that. That's the level the second year comps will get to. So obviously, you can go back to your AP notes, you could go to your textbook, you could watch a YouTube video and go into this in more detail if you wanted to. But for comps purposes, as long as you know this equals this, that equals that, you'll be fine. Then, of course, you can get some general questions about circulation. So first we'll start with the big picture, and then we'll talk a few specific blood vessels that might come up. So remember, with systemic circulation, how we get blood from the heart out to the body tissues and then back. Remember the big picture pathway. The left ventricle pumps blood into the aorta. We already showed that on the picture that we went over earlier. Notice it's in red, so this is oxygenated blood. The aorta then gives off branches that we call arteries, and the arteries will take blood to particular regions of the body. So some go to the head, the brain, the arms, the legs, the kidneys, the liver. So there's specific arteries that take blood to certain places, and those are all branches off of the aorta or branches off of branches, but they're all taking oxygenated blood to your organs and tissues. Then once we get into the nooks and crannies of the organs and tissues, we get into these more tiny microscopic blood vessels that we call arterioles. Then it goes into the smallest of blood vessels called capillaries. So remember, capillaries are the smallest of blood vessels. They're very thin, they're porous, they're very leaky. And for that reason, remember, in capillaries is where exchange happens. This is where oxygen leaks out into the interstitial fluid. And that's how cells essentially get access to oxygen. And it's not just oxygen, glucose leaks out, amino acids, vitamins, minerals, electrolytes, all that stuff. In the capillaries is where it's leaky, where now this stuff can leak out into the interstitial fluid and then get access to the cells. And of course, the capillaries can also pick up things from the interstitial fluid. So waste products like carbon dioxide can diffuse into the capillaries and then be taken away. So capillaries, remember, is where exchange happens. So now this is written in blue because this is deoxygenated. We just had a bunch of oxygen leak out. So this blood is lesser oxygenated at this point. And then the blood's going to flow into little veins called venules, then into larger veins, then into the vena cavas, and then from there back to the right atrium, and then we're kind of back to where we started when we went over the heart earlier. So keep in mind, that's the big picture of circulation. We'll mention a few specific arteries down here, but that's the big picture you want to keep in mind. And then remember, arteries are high pressure relative to veins, because remember that the heart is pumping directly into the arteries. So it's pushing blood into the arterial system. So there's a pump at the start of it. That's going to create higher pressure in arteries relative to veins. Because veins, by the time the blood kind of gets further and further from the heart, by the time it goes through these microscopic vessels called capillaries and then trickles out into the venous side, most of the pressure is dissipated. So arteries are known for being high pressure relative to veins. If you nick an artery, the blood comes squirting out. If you nick a vein, it comes dribbling out.
The
Generally
circulation
speaking,
stuff.
go
Oh,
ahead.
sorry.
No, go ahead.
I'm just like brain is moving outwards. I'm in 8 classes right now, so I'm trying to keep everything straight. But
Sure.
circulation issues, if it's not due to some sort of actual physical blockage in Western, do we attribute that to a weak heart?
That's one possibility. Yeah, I mean,
Obviously, yeah, there's a million possibilities, but
there's lots of possibilities. I mean, if somebody is having poor circulation, I mean, first off, you want to know, like, well, is it systemic? Like, is every area of the body equally not receiving adequate stimulation, adequate circulation? Then it could be a blood volume issue. There could be it could
mm,
be internal bleeding or something. So there could be a blood volume issue, and that's causing a drop in pressure. So the blood's not circulating, less volume to go around. It could be a heart problem, right? The heart
what
could
about
be
like
weakening.
Raynaud's? Or
There's
is
a thought.
that
That's
Raynaud?
that's more of just a local blood vessel obstruction. So that's another possibility, right? It
Oh,
could,
okay.
if it's just in a certain area, then it might be something local in those blood vessels. So it could be that the arteries are blocked, like from, atherosclerosis or something like that. Or sometimes the arteries are spasmed. They narrow too much, they get too constricted. And that's what
Mm,
happens in Raynaud's. The blood vessels go into a vasospasm,
hmm,
but typically that's only a localized thing, affecting the hands and the feet.
interesting. Okay, cool.
Yeah. So again, a lot of possibilities. So remember, arteries carry, generally speaking, oxygenated blood. Veins carry deoxygenated blood. Remember, we already mentioned the exception, the pulmonary arteries and the pulmonary veins are the exception to that rule. So you want to know some of those big picture differences between arteries and veins and things like capillaries or where exchange happens and stuff like that. As far as a few specific arteries that might come up, remember that the aorta gives off these branches that are called arteries, and the aorta has different sections. So at first, the aorta is going in an upward direction. So right out of the left ventricle, the aorta is going in an upward direction. So we call that section the ascending aorta. There are two branches that come off the ascending aorta, and they're the left and right coronary arteries that take blood to the heart muscle. So this is the blood that's nourishing the heart muscle, giving the heart muscle oxygen and glucose, the resources it needs, the raw materials it needs to keep pumping. Now, a couple pathologies, now we're getting a little bit into pathophys here. A couple pathologies related to that is if those blood vessels, those coronary arteries are obstructed in any way, whether it be they're narrowed because of some kind of vasospasm, like what we're talking about with the Raynaud's, but just affecting the coronary arteries. If they're obstructed because of, atherosclerosis, high cholesterol contributing, and other factors, of course, other factors contributing to hardening of the arteries and plaque accumulations, what's going to happen is the heart muscle won't receive adequate blood flow. Usually it might start out in the form of angina, where the heart's still getting enough blood flow for its like basic resting functions. But when the person increases their activity, when they start exercising or something, they notice a cramping or squeezing or, tightening sensation in their chest. But if they slow down, if they stop exercising, if they slow down whatever they're doing, generally it goes away. That's what we call angina. And angina doesn't result in any heart muscle death. It's basically just cramping of heart muscle because when the person increases their activity to a certain degree, the heart muscle is not getting enough oxygen and other raw materials for that level of activity. So essentially it cramps. That's what we call angina if it's just at that level. However, if it's a more significant blockage affecting the coronary vessels, then it could be to the point where it's not even enough raw materials for the heart to even do its moment to moment resting functions. And that's when the person will start to develop death of heart muscle. Like heart muscle will literally start to die from not having enough, oxygen is usually the key thing, not having enough oxygen. And so some symptoms overlap with angina. There could be like a tightening pain in the chest, but it also tends to radiate more like down the left arm up to the left jaw. shortness of breath, sweating. They may lose consciousness, depending on how much heart muscle death there is. It really all depends on if the heart, like, does the heart completely stop pumping? Then they'll definitely lose consciousness. But if blood is still flowing, if blood is still being pumped up to the brain, they may not lose consciousness, but there can be some areas of heart muscle death. That's what we call a myocardial infarction.
Is this must have lots of causes, I'm guessing, or is it mainly like a blockage in the vessel that is like cholesterol or something?
This condition is a blood flow obstruction. So, I mean, it could be related to atherosclerosis, which can be, of course, affected by cholesterol. So it could be created by plaques that accumulate in the coronary vessels over time and little by little obstruct the vessel. It could be caused by like a blood clot, and that could occur more suddenly because sometimes there'll be a blood clot from another area that breaks off and travels, and then it suddenly gets stuck in one of the coronary vessels. So that could be more sudden. It could be due to like a vasospasm. Sometimes, for unknown reasons, the vessel might go into a spasm and cut off the blood flow to the heart. But basically, it's always like by definition, a myocardial infarction is always death of heart muscle due to a lack of blood flow. So there might be a few different things that might cause that lack of blood flow, but by definition, like this condition is always a lack of blood flow leading to heart muscle death. So those are a couple disorders related to the coronary arteries. Then we've got the branches off the arch of the aorta, and there's 3 blood vessels that come off the arch of the aorta. There's the brachiocephalic trunk, but then that's a very short vessel. It quickly splits into the right common carotid artery that takes blood up to the face, head, and brain, and the right subclavian artery that ultimately takes blood to the right arm. And there is no brachiocephalic on the left side. Basically, the left common carotid artery and the left subclavian artery just come directly off the arch of the aorta, and they supply the left side of the head, face, brain, and the left upper extremity. That's one of those nitpicky things that sometimes comes up on things like comps. You want to make sure you know that the left common carotid and left subclavian just come directly off the arch of the aorta. And when it comes to the right common carotid and right subclavian, first, there's this blood vessel called the brachiocephalic trunk, very short, that then splits into those 2 vessels. A little nitpicky. It's not going to affect your day-to-day life knowing that tidbit, but it is one of those just anatomical details that could come up on an exam. All right. And then as far as the blood vessels that take blood to the brain, you have the right and left internal carotid arteries. Those are branches off of the common carotid. So the common carotid will split into branches, and the internal carotids go to the brain. And then on the back side, we have vertebral arteries that come up along the cervical spine, and those will converge into the basilar artery, and it'll take blood to the back side of the brain. So you just want to know that those are the primary arteries that are taking blood up to the brain tissue. And disorder-wise, if somebody gets an obstruction in either these vessels or the branches off of those vessels in the brain, because most of the time when somebody has, a blood flow obstruction of the brain or a blood flow obstruction of the heart muscle, it's not like the main arteries, it's the smaller branches that come off of those arteries. So the person may not have a blockage in the common carotid artery or the internal carotid artery itself, but then once you get up into the brain and it breaks up into smaller branches, they get an obstruction somewhere in those smaller branches. And bottom line is, if you get an obstruction in any of these arteries, it's going to cut off blood flow to the brain. And then it's going to lead to death of brain tissue. And that's what we call a cerebral vascular accident. You could say CVA for short, also known as a stroke. So a stroke, by definition, or cerebral vascular accident, is a obstruction of some sort, some kind of issue that's depriving the brain of blood flow, leads to brain tissue death, and then the person's going to start to get compromised bodily functions for whatever that area of the brain controls. So it's, it can manifest in a lot of different ways because it depends on what region of the brain is affected.
I didn't realize a stroke. Listen, this is not my specialty. It will be someday, but I
Mhm.
didn't realize a stroke was due to lack of blood to the brain. I must have known that. I thought it was more neurological. That's interesting, though. It's related to the heart.
Well, it's not related to the heart.
Oh,
The
you're saying it's just related to these vessels
It's related to the
that
vessels, yeah, which that's
that
that's a little
okay, if
different.
they get blocked. Okay, I see.
Right, right.
Got-
And just to kind of clarify a little bit, like what you said, those two things are not mutually exclusive. You said like I didn't know it was related to lack of blood flow. I thought it was neurological. Like those things aren't mutually exclusive because it's like the lack of blood flow is causing
Yeah,
damage to the brain. So they do
totally.
ultimately have a neurological problem when all is said and done. Yeah. Now, one key thing when it comes to stroke is the odds that two blood vessels on both sides of the brain, one on the right, one on the left, are going to get obstructed and cause death of brain tissue at the same time is very unlikely, just, statistically unlikely. So, more than likely, this death of brain tissue is happening either on the right side of the brain or the left side of the brain. So, a very key manifestation when it comes to strokes is signs and symptoms that appear on one side of the body. And remember, they typically appear on the opposite side of where the stroke occurred. Because remember that the right side of the brain controls the left side of the body and vice versa. So, very commonly, if you see one sided symptoms manifesting, particularly if they're coming on like kind of suddenly, the first thing you have to rule out is this person having a stroke? So, you might see muscle paralysis or weakness on one side of the body. Could be the face, it could be the arm or leg. It all depends on what region of the brain is being affected. So one-sided paralysis, one-sided altered sensation, some kind of numbness, some kind of tingling, something along those lines. Again, depends on what area of the brain. Is it affecting the motor part of the brain that controls muscles? Is it affecting the sensory part of the brain? It all depends where this is occurring as to what manifestation they'll get. But typically, it's like one-sided symptoms. And then, of course, there's things that don't really have a side per se, right? Like you might see the patient having things like confusion, slurred speech, disorientation. They might lose consciousness. It all, again, just depends on what area of the brain is affected. It's kind of remarkable. Like, I don't know if there's a thing that's for this, but like, it's kind of remarkable, like, how many newscasters seem to have strokes because there's so many videos on there on YouTube of a newscaster giving, like, giving the news and having a stroke right there. Like, they start slurring their words, start saying things that don't make sense. There's so many YouTube videos of that happening. That's just like, why are all these newscasters like, because the odds, right? There's only so many newscasters in the world.
They're
And the
reading
fact that
too
there's,
many. They're reading the teleprompters and getting all verschnorkeled.
yeah, maybe, probably a lot of stress involved.
Yeah. But okay, wait, sorry. My brain, I don't know why is looping on one thing. A stroke can also be caused by atherosclerosis, potentially.
Sure. Yeah, any kind of obstruction of blood flow to the brain. Yeah.
Yeah, interesting.
So yeah, that could be atherosclerosis. Same thing that cause a myocardial infarction. It could be atherosclerosis that accumulates little by little over time. It could be a blood clot that develops either originally in that region, or it could be a blood clot that broke off from somewhere else and then traveled up there, and that could come on very suddenly. So yeah, the
What's the
same
main cause
things.
of blood clot? I guess
Well,
I've never learned the like Western. I'm sorry, I know this is not part of your review, but
most
like
commonly
that
on
the
an
cells are
injury.
clotting. Oh, okay. Or like they say not to get on a plane after surgery because that can.
Yeah, the pressure changes in a plane might contribute to a blood clot maybe breaking free. That's a possibility. It could also contribute to the pressure changes might contribute, like somebody has a wound that was stitched up or something. It can contribute to bleeding just because the pressure changes when you go up on the plane.
But a clot is commonly coming from some sort of injury, like initially, like
That's oftentimes the reason. Like, I mean, normal clots
Oh,
usually develop because there's some sort of injury to a blood vessel
right.
that the platelets are adhering to and trying to seal and heal. But of course, sometimes the clot just develops pathologically. Like there's no injury to speak of. I mean, there's nothing to point to that caused the clots. It's like sometimes clots occur just because of like sedentary lifestyle. Like so, yeah,
Yeah,
they'll
I was
use
gonna say like the quality of the blood is not moving or something. I'm thinking more what Chinese medicine, but
yeah, like chronic dehydration, which in Chinese medicine we might call blood deficiency, something like
yeah.
that. If the blood's more concentrated, that can contribute maybe to blood clotting, especially if you combine it with lack of movement. So sometimes it just happens for things like that, for reasons like that. Sometimes it's as a result of an injury, the blood clot forms.
Okay, cool.
Yeah.
Thanks.
Mhm. And of course, sometimes people have genetic disorders that predispose them to abnormal blood clotting. And then congestive heart failure, that doesn't relate to any one particular blood vessel or anything. We'll just mention this as its own thing. So congestive heart failure, want to make sure you don't confuse it with myocardial infarction. Congestive heart failure is not a blood flow obstruction. It's more of just a chronic weakening of the heart muscle due to a possible genetic defect, due to the muscle being worked beyond its capacity for a period of time. So, for example, let's say a person has chronic hypertension. So, in other words, there's more pressure in the blood vessels, higher pressure than normal. So now the heart has to work harder to overcome that pressure to keep the blood circulating. So over time, the heart's working harder. And eventually, like any muscle, if you work it too hard, you go to the gym and you lift heavy weights, well, eventually, like, oh my God, I can't even move my arms. So imagine that same kind of thing little by little happening with the heart muscle. It's being worked beyond its capacity. So eventually, little by little, starts to fail. Now it's not ejecting blood adequately. So the tissues aren't receiving adequate blood flow. And the blood backs up in the heart chambers, and then it backs up into the lungs, and then it backs up into the systemic veins. And it leads to things like fatigue, chest pain, significant shortness of breath because, the blood's backing up in the lungs. We're not like oxygenating it adequately. They might cough up pinkish sputum because of the backup of blood in the lungs. You might see edema throughout the body because of the backup into the veins. So this is what they call congestive heart failure. The heart, the lungs, the tissues become congested with blood backup, and of course the heart is failing. So congestive heart failure. This is more like a chronic thing that happens little by little over the years for a variety of factors. Unlike a myocardial infarction that could be sudden, can come on out of nowhere. Now, somebody with a history of myocardial infarctions, that can contribute to congestive heart failure because that could be part of why the heart muscle is weakening to begin with, right? If somebody has a lot of areas of heart muscle death, I mean, that might lead to a weakening of the heart. It just depends on like how large, we obviously know people that have heart attacks and then they go on to live, you know, decades after that. They get a stent put in or something like that. They go on blood thinners, whatever it might be, and then they live decades beyond that. But depending on like how much area of heart muscle was damaged in the heart attack, it could contribute to chronic weakening of the heart that could set the stage for congestive heart failure. It just all depends on how much heart tissue is damaged. Now, as far as pharmacology that comes up, as I mentioned last week, they don't really get into a lot of the overly technical pharmacology on comps. It's usually very big picture. There's only 6 questions. So it's mostly knowing drug categories. So you just want to know things like for high cholesterol, the person's usually given what they call statin drugs. That's the general category, statin drugs. So things like Lipitor fall into that category. And same kind of thing, they might be put on what we call blood thinners or anticoagulants. That would reduce clotting. That would reduce the formation of blood clots. And something like an aspirin falls into that category. They don't tend to ask a lot of specific drug names, but something like an aspirin could come up to just know that, like, why might a 55-year-old who had a prior heart attack take an aspirin every day? You want to know that aspirin essentially reduces coagulation. It thins the blood. It prevents blood clotting. Then a couple things with blood pressure. There's a few categories. So you want to make sure you know that normal blood pressure nowadays, what's considered normal, optimal, is a systolic number, the top number, less than 120, and a bottom number, less than 80. So it used to be 120 over 80 was considered to be perfect. Like if you were 120 over 80, that was exactly it. Now they actually say, aim for a little bit less than that. They don't really give an exact number. Like, it's not like you need to be 118 versus 117, but less than 120 over 80. Now, of course, obviously there is a point where it can get too low, but usually we're not as concerned about that. That's usually not as much of an issue. People usually have more this tendency towards high blood pressure. So, yeah, if it goes too low, the person's going to be passing out and things like that. The person would know that, okay, we have a problem on our hands. It's too low. There's not enough pressure to overcome gravity and their brain's not getting enough blood flow. So they're getting dizzy and passing out. And then, you would treat that if they were having those problems. But as long as the person's not really having problems, just the lower the better. As long as the blood's still circulating, then yeah, lower the better. But usually you're thinking like a 115 over 75, like something like that. There obviously is a range where it gets too low. If the person has a top number in the 120s, but the bottom number is still less than 80, then that's what they call elevated. So top number in the 120s, but the bottom number is less than 80. They refer to that as elevated. And that's more like, we'll keep an eye on it. It's on my radar now. I'm going to keep an eye on that, but they're not likely on any medications or anything like that. Stage 1 hypertension is where either the top number is in the 130s or the bottom number is in the 80s. It doesn't require both. If either of those things are true, then that would be stage 1 hypertension. It could be either of those. So in other words, if somebody's blood pressure was 135 over 75, that would still be stage 1 hypertension. This is where they're going to probably advise medications. Stage 2 hypertension is basically anything above 140 for the top number. And again, or it doesn't have to be both, or anything above 90 for the bottom number, for the diastolic number. This is where they're really going to push medications. So if the person really didn't want to take them, but now they're getting into this range, this is where they're really going to push because, now there's a much greater statistical likelihood of some kind of cardiac event without intervention. So you want to just recognize those ranges. You want to recognize if they give you a blood pressure on the comps, like when's it considered normal? When's it considered stage 1 hypertension? That kind of thing. Pulse pressure is just a definition that you want to know. So pulse pressure is just simply the difference between the systolic pressure and the diastolic pressure. Or you could say the top number, the bottom number. It's just simply the difference between the two. So if somebody has a pressure of 120 over 80, the pulse pressure would be 40. So it's just a definition you want to know. It doesn't get any more detailed than that on comps. Now, an applicable disorder here, basically a disorder related to blood pressure, is shock, medical shock. This is when there's a significant drop in blood pressure. So if there's a lot of ways you could basically define shock, but essentially it's usually an acute situation. It's an acute failure of the circulatory system to deliver blood to the organs and tissues. There's typically an extreme drop in blood pressure. And remember that the body will compensate usually by diverting blood flow to the most essential places. So the body will typically compensate by cutting off blood flow to the superficial tissues and cutting off blood flow to the extremities and diverting the blood flow to the vital organs. And that's the reason when you touch the patient on the surface, their skin feels cold and clammy, like a cold, oily sweat. Their skin might look cyanotic, kind of ashen, like grayish, bluish. If you took their typical pulse, the radial pulse, it'd probably be pretty weak or hidden, hard to find, because again, we're cutting off blood flow to the extremities. They're probably doing some rapid breathing. They might be thirsty. because when your blood pressure drops, you want to replenish your body fluids. So you might be thirsty. In Chinese medicine, this is what we might think of as yang collapse. Cold extremities, bluish discoloration, feeling cold. This is what we might think of as yang collapse. So you want to know just generally like what is shock, big picture. And then remember there's certain categories of shock, different causes. So there's hypovolemic shock, that's due to bleeding. So like, gunshot wound or something, a stab wound, the person's bleeding out and oh, they're going into shock. Well, it's because they're losing blood. Of course, their blood pressure is dropping. Could be internal bleeding. Maybe the person doesn't realize they're bleeding internally. But either way, their blood volume in their blood vessels is going to drop. So that's what we call hypovolemic. And again, different categories because they each need different treatments, right? With hypovolemic shock, you have to stop the blood loss and they need a transfusion. That's the intervention they need. Stop the bleeding, transfuse them. Cardiogenic shock would be if it's due to a heart problem. Like if somebody has congestive heart failure, obviously the blood's not going to circulate very effectively. That's due to a heart problem. So maybe they need a heart transplant. Maybe their heart needs to be defibrillated, if they're having a myocardial infarction or something. So it just depends on the specifics there. Obstructive shock would be some kind of major blockage. It's right in the name. Now, keep in mind, like this has to be a major blockage to lead to systemic shock. If it's a little blood clot in the foot, well, that might affect blood flow in the foot, but it's not going to cause systemic shock. This would have to be something like a tumor's compressing the inferior vena cava and creating a major backup, something like that. Some kind of very serious injury is, putting pressure, maybe there's some significant swelling and it's putting pressure on the aorta. Again, it have to be some major obstruction like that. And lastly, distributive shock. This is due to excessive vasodilation. If the blood vessels systemically dilate, that's going to cause a drop in blood pressure because essentially there's too much space now for the amount of blood the person has. So there's not enough, there won't be enough pressure created. This is what happens in anaphylactic shock. The person gets stung by a bee, for example, they're allergic to bees, or they eat a peanut, they're allergic to peanuts, and it creates this significant histamine release throughout the body, and it causes the blood vessels to excessively dilate, blood pressure drops significantly. That's anaphylactic shock. And that's in this category, that's under this umbrella. So you want to just be familiar, just the level of what's here. You don't have to do significant independent research, just know the basic definitions, know what's here. Any questions?
Sorry, my ah. Sorry, iPad being weird. For Comps 2, we're basically branching out from just basic anatomy and physiology into pathology or pathophysiology, right? That's
Yeah, pathophysiology, the ONE series, the orthoneuro 1 and 2, and pharmacology.
I haven't taken pharmacology.
Are you
That's
in the
after.
are you in
No,
what
not in herbs.
you're in the MS, what is it, the MSAC?
Yeah.
Yeah, so you'll get a version of the exam that doesn't include pharmacology then.
Okay, I was concerned. Okay, great.
Yeah, if you may recall, maybe not, but if you go back to the first week's recording, I mentioned that the pharmacology is if you're in the full like doctoral program with the herbs and everything, like pharmacology is included. If you're in the MSAC program and you haven't had pharmacology yet, people in that program get a different version of the bio exam where basically
I'm
all the
sorry.
questions are the same except for the pharmacology.
Got it. I missed the first week because I forgot to sign up, so I'll watch it.
All good.
Thanks.
All good. All right. So the last thing, and I guess this won't relate to you, so you could stay if you want or not, but for the purpose of the recording, the medications that treat hypertension. And just FYI, you can see there's a lot of hypertension meds. And the test bank, there's a pretty high representation of hypertension meds in the test bank for the pharmacology part. And I remember there was one time where like almost all of the pharmacology questions just came right from here. Because again, it's just random chance, right? There's a test bank, whatever the software pulls in, So there was a time where it was like out of the 6 questions, like 5 of them were just all from right there. So essentially, when somebody has high blood pressure, when they have hypertension, there's a few ways we can treat it. One way is to lower the overall blood volume, because if there's less blood volume, well, then the vessels won't be as full and there'll be less pressure. So diuretics come into play for that. And diuretics basically do the opposite of ADH. Remember the hormone ADH is anti-diuretic hormone. So ADH causes us to hold on to more fluids, causes us to retain water in the vessels. Diuretics do the opposite. They cause us to urinate out more urine, more water. So we're eliminating more water from the bloodstream and sending it out in the urine. So that can be one of the ways of treating blood pressure. Now, a little bit of a caution, diuretics promoting urination like this can alter our electrolyte balance. And the most critical electrolyte that most easily comes out of balance is potassium. So this can result in potassium depletion. So if a person on diuretics starts showing signs of like abnormal heart rhythms, muscle twitches or spasms, you may want to send them to their MD to have their medication reevaluated. They maybe need a different dose or need to get on a different type of medication. So you want to know those kinds of potential side effects. Then there's beta blockers, because another way we could treat hypertension is to make the heart beat less forcefully. Also cause blood vessels to dilate. So beta blockers, you may recall that there's receptors on the heart muscle called beta receptors. And these are the receptors that respond to epinephrine and norepinephrine. Like basically they respond to sympathetic stimulus. So if you block those receptors, the consequence is the heart beats less forcefully because it's not getting that sympathetic stimulus. That sympathetic stimulus has been blocked, it's been lessened. So the result of that is a less forceful heart contraction, a lower heart rate, and therefore lower pressure. All other things being equal, that should lower the pressure. So typically those medications are given for somebody with hypertension, but they could also be given for somebody who has panic attacks, they get anxiety, or they get palpitations and things like that. People could be on those medications for those kinds of reasons too, but they're definitely given for hypertension. Then there's what they call ACE inhibitors. Now this the full mechanism is written down in the endocrine handout that we'll go over in a couple of class meetings. But you may remember that there's that whole series of reactions where there's the kidneys release renin, and then renin reacts with angiotensinogen, and then angiotensinogen gets converted into angiotensin 1. And finally, angiotensin 1 reacts with this enzyme ACE that converts angiotensin 1 into angiotensin 2. Now, all that's spelled out on an endocrine handout. So right now, it's okay if you don't remember all those steps. But the bottom line is angiotensin 2 has a number of effects that raise blood pressure and raise blood volume. So ACE inhibitors, by blocking that enzyme, ACE, angiotensin 1 never becomes angiotensin 2, or at least it's lessened. It depends on the dosage, right? You at least lessen the amount of angiotensin 1 being converted to angiotensin 2. And by lessening the amount of angiotensin 2, you lessen those effects. And so therefore, the blood volume, the blood pressure comes down as a consequence. Then, of course, another way is to just give angiotensin 2 blockers. So sometimes the way of treating is, okay, let ACE do its thing. Let angiotensin 1 be converting to angiotensin 2, but there's drugs that block the angiotensin 2 receptors. So even though there is angiotensin 2 being made, it doesn't have the effect it normally would because the receptors for it are being blocked. So that's just another approach. And sometimes, you might think, well, why do they need all these different approaches? Why not just give everybody ACE inhibitors? You know how it is. Every medication has its side effects. Some people tolerate one method versus another. They tolerate one type of drug better than another. So you want to have different options. And then lastly, and then that's where we'll end it for today, is calcium channel blockers. You may remember from AP3, and it was a while ago. Calcium rushes into the heart muscle, and that's what binds to the troponin and all that, and therefore activates the actin and myosin proteins, causing them to bind. So if you block the calcium channels, lesser amounts of calcium get into the sarcoplasm of the heart muscle, and therefore less actin and myosin cross bridges get activated, and therefore it results in a less forceful heart contraction. So basically, calcium channel blockers cause the heart to beat less forcefully. And all other things staying the same, all other things being equal, if the heart's beating less forcefully, that should cause the blood pressure to come down. So again, lots of potential avenues to treat hypertension. This isn't even everything. I mean, there's other things that you can give. This isn't even all of them, but these are the ones that are pretty critical for comps. All right. Is there any questions?
A million, but for another time.
All right, fair enough.
Thank you very much.
All right, you're welcome. And thank you, everybody, watching the recording. So remember, if you're, I don't know if everybody here is keeping up with the recordings, but remember next week we don't have class. So there won't be any new recording next week, week 3. But then we meet again on week 4. And so there'll be a new recording 2 weeks from now. So anyways, we'll pick up here next time and then, of course, go into other things from there. So see y'all later.